Recording in progress.
It is Tuesday, September 17th at 9:39 a.m. The board meeting of the Oregon State Board of Nursing is now called to order. A notice of this board meeting was published by Rachel Prusak, Executive Director, in accordance with Open's meeting law. If necessary, the board may also meet in executive session as authorized by ORS 192-660 sub 1, ORS 192-660 F, H, and L, ORS 678.126, ORS 676.165, and ORS 676.175 sub 1. Board members and staff stating they are present are attesting to understanding the confidentiality of executive session and have taken steps to ensure that executive session proceedings are not observed or heard by anyone not authorized by Public Meetings Law, ORS 192.660. Is there a roll call by our secretary?
Aaron Green,
Here.
Linda Stanich. Here. Margaret Hill, present. Claire McKinley Yoder. Here. Joni Callis. Here. Marcus Cooksey.
Present.
Shell Chow.
Here.
Oleniki Toabola.
Here.
Yvonne Yanduan.
Here.
There being a quorum present, I declare this board eligible to conduct its business.
Is there a staff roll call? You don't have to hold it now, though.
Microphone investments. Good morning, everyone. Limited staff here today for our workshop training strategic planning. We have Kimberly Goddard, Chief of Staff. We have Ella Rausch, Board Counsel. We have Brandy Ritter, Executive Assistant. We have Phil Young, IT, and myself, Rachel Prusak, Executive Director.
All right, thank you. It is 9:41 a.m. The Oregon State Board of Nursing will now meet in executive session to consider information or records that are exempt from public inspection, including advice from legal counsel, and to consider information obtained as part of investigation into licensee or applicant conduct. This executive session is held pursuant to ORS 192.660 sub 1 and ORS 192.6602 F. Members of the news media may remain during executive session, but are directed not to report on, record, or otherwise disclose any deliberations or information discussed during executive session. If you are a member of the public, please note that public video streaming will be unavailable during executive session. No final action will take place in executive session. And at the end of executive session, the board will return to public session for the purpose of taking formal action on matters discussed in executive session. While the board is in public session, the public video stream will be available. It is estimated that executive session will end at 11:30 a.m. 11 a.m. It is. It is 11:05. The board is still meeting in executive session. The new estimated end time is 11:15, 11:20. It is now 11:17 and the board will now exit executive session. It is 11:18 and the board will now enter public session. The board will be taking a break until 11:30. We are returning from break and we will now move on to the strategic plan presented by Executive Director Rachel Prusak.
Yeah, the strategic plan and the DEIA plan has been in several packets the last few months that we've been discussing it, but it is also in this. But I do think seeing the PowerPoint presentation together is helpful. So, last night I was prepping for this discussion on strategic plan, specifically leaning into the DEIA plan and focus, and we'll talk a bit about customer service too, but really hoping we could have a public discussion with the board about the DEIA plan. But, while it's really great to be transparent, it also does bring barriers as we work thinking out loud about DEIA and strategic planning. As the executive director for the last year, I've been really learning how to lead these discussions, and I'm committed to you all that they will keep improving as I'm learning with you all. I wanted to let you know that I meet with the other health professional regulatory boards monthly to collaborate on lots of things. And currently we're part of the cohort meeting regularly monthly with the Office of Cultural Change. And we're really learning together how to center DEIA or DEIB, depending on the agency. But how to center that, and they're really supporting us. So we did also, because we're meeting about this, recently start a conversation about how to partner across the health practitioner regulatory boards, because some of us are smaller. And so while we're trying to collaborate more, one of those things is how we can maybe make a larger DEI committee versus the smaller ones in each smaller agency. I think the diversity of the larger group will lend more to learning from diverse voices and, of course, just benefit everyone that's involved. I want to share, while I was prepping for this, I had the Emmys on in the background. Did anybody watch it? I had not watched the Emmys in a long time. It was really, really good. Learned about shows that I want to watch now. But anyhow, John Leguizamo, gets up and he starts presenting, and you probably all know who he is. But he starts with a joke about a DEI hire, and then he goes into representation, and he really challenges how centering DEI and representation makes everything better. And I was really captivated by this because it really shows, while there are DEI is getting mocked in spaces, we in Oregon and our governor and the state is saying, no, agencies need to center this and it has to be part of our plan. And so it's really an expectation of all the agencies in the enterprise to center it and lead on this. And so I'm really honored to be a part of that. So with that, I know it kind of seemed unconventional that, it's really the board's work, and here I am presenting you with the plan to kind of approve it. But when I started this job, just so you know, the DEIA plan was due the month before I arrived. So therefore, why I started working on it, why I leaned in, why I tried to understand what the governor's expectation, what the state's expectation, what other agencies had done, what I could learn from them, and what I could bring to the board as a baseline, giving you now the opportunity to have read it a few times and maybe at today's conversation, ask questions, make comments, make edits, make suggestions. So that's what I'm hoping that we can do today. With that, can we just start with, because I know I kind of brushed over the work that your leadership team did when I brought it to you to originally vote on, but really the mission, the vision and the values. Can you go to the next slide? Right here. So the Oregon State Board of Nursing is committed to protecting the public through regulatory excellence and promoting the wellness of our nursing professionals. And so really what we did here, your leadership team over 2 days, which of course is myself, need me to be closer? How's that? I want to make sure it's accessible. So, okay. You have licensing manager, investigations manager, operations manager, communications manager, chief of staff, HR, and then myself. And really thinking about, nurse wellness as public protection and how we can incorporate into the mission. And then we added a vision. We didn't have a vision. And from that is a safe and healthy public promoted through a healthy and diverse nursing workforce. Can you go to the next slide? And then the next one. And the next one. Right here. So I'm going to start here and then we can kind of zoom in to the DEI plan section and where we're at. And then really just have a discussion. So the imperative, kind of the statement was, the DEIA is critical at Oregon State Board of Nursing. Our DEI committee is driving the implementation of a DEIA plan with key strategies for improvement. And objective 1, to increase access to our services. The strategies we were going to use are improve language access services on customer service phones, provide multiple pathways and languages to submit complaints, review, update policies, procedures, and Nurse Practice Act with a DEI lens. Do you guys have any questions about that? Thoughts, comments? Okay. Objective 2, to increase diversity of external partners, strategies, ensure diversity within board members, ensure diversity within rule advisory committees. And again, once we kind of zoom into the DEI plan, it gets a little bit more in depth. Any questions about that one? And then objective 3, recruiting and hiring with an intentional equity lens and inclusive language on job postings, review, update, and monitor hiring processes, including recruitment, interview processes, and hiring outcomes. So at a high level, we're kicking off the DEI committee this month. We are in conversations with our investigations manager and licensing manager, leading the conversations of really understanding how we can improve language access over the phone, in our emails and our complaints. Of course, we have been doing much more external communications and partnership wherever I am able to reach out to those who may be interested in being a board member, reach out to those who may be interested in being on the Rule Advisory Committee, and ensuring that I'm collaborating with external partners that may not have been brought in previously. And then recruiting and hiring, I can give an example of really updating our job postings. The last time we posted for a nurse investigator, the way it was posted, how it was posted, where it was posted, we had 4 applicants. The most recent posting, we had 78 applicants. And so I think it's a real example of our HR leader on how they're working. They connected with our nurse investigators. They asked how they could update the posting, and then we made sure that we posted it everywhere that we could think of, including paying for it to be on LinkedIn. So that's exciting. We're in the process now of doing the interview process. I think now if we could go to the DEIA plan. Yeah.
How do you guys find your Rules Advisory Committee members? How do you make those decisions?
Yeah, so great question. So I, since coming, have been trying to increase how we communicate. And currently we're in communication on switching our listserv as we use it now to Gov Delivery. We just started those communications, so it's even going to be wider. So that's future. But right now, anybody who's ever signed up on our listserv gets an email promoting it. Anytime we are in, say, a deans and directors meeting or any other kind of community meeting, we announce it. I'm adding it on my LinkedIn. You all are always welcome to also add it. I have partnerships with Oregon Healthcare Association, Oregon Hospital Association, Oregon Nurses Association, SEIU, Black Nurses Association, Hispanic Nurses Association. I did that listening tour to make sure, hey, are you not on our listserv? Get on our listserv. Hey, these are how we're doing that. So since I've arrived, I've really made sure anywhere it can be mentioned. And our rule advisory committees, whether it was 47, 63, and currently 21, are the largest they've have been, and have definitely brought in different perspectives and voices. But with that being said, one of the things that I wanted to ask you all, could you go to September, I guess the objective one, let's see. Keep going. Right here. Are we able to make that bigger? So the next steps is really saying if you all have groups that maybe OSBN hasn't partnered with historically and you have recommendations on that, please let me know. So for the September, what I imagined we would be doing September 2024, when this was submitted, initially December 2024, and then we discussed it, met with the leadership team to update it, met with you all to vote on it. Here we are, September 2024. Was I, as your leader, able to get these things done? So, and there may be times that we don't, and I'll come back to the strategic plan to kind of show where we put the timelines and what we're hoping we can do. So here is the create the DEIA committee. So I've been putting a call out for that for staff since the beginning of the year. And on September 25th, it is kicking off. It is in good hands. So staff from each department and managers volunteered. And then our fearless policy analyst who has experience leading this work, Laura Blackhurst, is really going to partner with me to lead the work. But what I'm hoping for in the future is it isn't just OSBN staff volunteers meeting to ensure that we can properly report out to the board and make sure that we're staying on target of this 4-year strategic plan, but really that I continue these conversations that I got a little too close to the mic on how we partner across the health professional regulatory boards, right? We're the largest board. We have 60 staff, and it really was hard to form this. So I could imagine, there are some that are 4 staff, 6 staff, 10 staff. So I'm really hopeful for that. And as we partner with the Office of Cultural Change from the governor's office. But what I thought we could have a conversation about today is what is this philosophy statement? And I didn't tell you all we were going to do this today. If we don't get to something today, that is fine. But what I did was some research on what a philosophy statement on DEI could look like. And I'm just going to present a couple of things that I found to start a discussion. And if we create one today, great. If we don't and we further the conversation about it, that's okay too. Again, like I'm making these targets. This is the first one that I'm supposed to meet that I've put upon us. But on that, the things that I was able to found that are typically in a simple philosophy statement on DEI is something as simple as OSBN is committed to fostering an inclusive environment where all voices are heard and valued. Things like we respectfully accept and contribute valuable ideas to achieve our shared goals. Those are really kind of what I've been hearing from you all, what I've been hearing from the governor's office, what I've been hearing from other boards is just this statement of, and I say it in so many words in this entire plan, but does this board want to have a philosophy statement to kind of go along with the work that the DEI committee is going to do? And if they do, what would it, sound like, look like? And I think there is that sentence of saying and statement of we're committed to fostering an inclusive environment where all voices are heard and valued. And that goes to who is part of our rule advisory committee, who is part of our board, who's part of knowing that we have public meetings. How do we make sure that that is happening and that we really do value it? We don't just say it. And that we accept and contribute valuable ideas to achieve our shared goals. And I've just really watched you all have discussions that show that, and listening to our partners when they show up on public meeting days. So I'm going to stop there and just really get feedback from you all. Really, the first time that we've been able to have this conversation, because in true government board fashion, it's hard, right? There's these things that I have to do as the director. There's all of this work that you have to do as a board to meet an executive session and public board. When do we have the time for this? So I wanted to make space here now that this has kind of been out there now.
I mean, I think having just that first statement that says we include all voices, that's a simple and powerful statement that it doesn't have to be specific, but it really says we welcome everyone without listing out any specific group. That way no one feels left out if we tried to list everyone out. I think that really speaks volumes and I think encourages people to participate. Plus, with thought of eventually having our board meetings migrate around the state so that more people can potentially come to our public meetings, that would go along with that statement where we're showing everyone we want you to participate.
Yeah, I can't tell you the listening tour. People were, I can't believe you came to me and I didn't have to drive to Portland, and they were beyond. And the goal now is not just me, but the board next year. When do we take a summer meeting, maybe in Eastern Oregon? When are we over on the coast? When are we in Southern Oregon? So absolutely.
Other board members?
I have a thought. People don't usually have trouble hearing me, but I like both of the statements that you made. I think one word that's really important is whether it's unity or united. And I really think that that word, because when you talk about the different groups that we actually have, the rule advisory, the board, but what are we all here for? And that's truly for a united front. So I do like that word somehow, wherever that can be incorporated into. I think it's important because although we seem like we're on our own little islands at times doing what we need to, when we're here, it's really the unity that's bringing us for the purpose of our mission and our goal and so forth. So
Yeah, I mean, I work with the policy analyst on everything you all mentioned to then go to the rule advisory committee and have those discussions, and then they bring it back to you, right? And so I see what you're saying.
I have two words popping in my head, and I think you used one already. And I feel it kind of describe what we do a lot. We accept and we respect each other. Because even if we don't have respect for each other's opinion, then are we truly accepting of each other's opinions?
Yeah, the way it was said was we respectfully accept and contribute valuable ideas to achieve our shared goals.
And I really think that that is spot on because throughout our discussions, even if we can't come to a unanimous decision, we appreciate each other's opinions. We accept what each other's saying, and we're respectful of each other. We don't belittle each other regardless of our views or how we see a particular case or how we read a particular rule or statement. And I think that really speaks to what we're looking for as a board and as an agency. Other board members? Respectfully united.
So what I could do is when we meet with the committee, I could kind of bring back the two statements I shared and the desire to incorporate Unity United, and then come back to you all with something. It could be kind of the committee's first charge. But I think that,
Just one comment, and I like your word united, but I'm wondering if it could ever be misconstrued as to, we all have the same singular thought, right? That we're not actually looking for diversity of thought or individual opinions on things. I don't know, I'm just throwing it out there.
no, it does give that connotation. So I think, united in respecting diversity, equity, inclusion, accessibility, but not necessarily united on every thought, because therefore then you can't accept every thought. And also, you all are the final deciders. You are the ones that make the decisions with all the information handed to you, whether it's unified or not. But the one thing that you're saying you're potentially unified in is this effort.
And I do respect that. And I think it's actually, it does bring a different perspective. I think if we were all fragmented though, in just what our purpose and our job is, that's why I feel like when we come together, it is kind of we're taking into account the respectful decisions, the respectful opinions, all of those things. But at the end of the day, the united front that we have, that's why I just figured it's a word that actually does define as far as what our role in the sense of the board member is. Not that you have to agree with me necessarily, but at the end of the day, however we come to that, it's united that we're coming for the best goal of our mission and so forth.
Right, like at the end of the day, we're here to protect the public. And that's our job.
And I think that can be added to it, of the balance of protecting the public with united in our mission. We can figure that out. So I'm just going to say it all one more time. It's funny when the leadership team for 2 days had, you save all those, you must have, we had, everything, and we're going back, and we were respectfully debating a lot, which is one of my favorite things to do. And then, we had a unified front and had to come to a decision and present to the board. This is the mission. This is our added vision. We did not have to change our values. Those values that stand are just what I think showed that OSBN already had DEIA at the center, but now it's how do we live them? How do we talk about them? And how do we ensure that everything that we do is connected to them? But so since we don't have sticky notes all over the room to have a debate for 2 days, I'm just going to elevate it, the few things, and then I will go to the DEI committee, and then I will come back to you all. But we're thinking that OSBN could potentially have a philosophy statement, a statement of philosophy that you will adopt, clearly explaining the board's position on diversity, equity, inclusion, and accessibility. That could be OSBN is committed to fostering an inclusive environment where all voices are heard and valued. And something like we respectfully accept and contribute valuable ideas to achieve our shared goals. And where we're unified is really in upholding our mission to protect the public while doing those other things. Any other thoughts to add to the debate, discussion? Okay. Thank you. All right. Okay, so then from there, again, we have a committee. I'm going to do lots of, potentially partnering with some of the groups that you all suggest or I am aware of that are, leading the work, in DEI, based on what I learned from the Office of Cultural Change, what other agencies are doing. And I'll continue to report back to you, what the committee is doing, who we've met with, who has presented to us. And anytime you all want, a presentation to you, you just let me know. For the next steps, again, increasing the diversity, we've talked about that. Can you go down one more time? I don't know if we need to start, I think, going into more. Nope, okay. Any other last words on this topic before I move into what we're doing for customer service, which is really important?
So, in the first section, strategic, what was this? Next steps, create, trainings and various trainings. Will we have access to those trainings?
So there are trainings accessible to board members, and I will make sure they're working right now on putting together a lot of resources. And so, this is one of the things that we keep talking about is we're tasked to do some steps of things before we have other steps. And so along the way, we're all learning. But I will make sure every resource I learn about. Some trainings come my way that just aren't going to work for our staff or our board, giving timing, but I'll start making sure as we're moving forward with this that anything I learn about that could potentially help you all will help you. And then I do know that the director of the Office of Cultural Change can also come speak to the board. So there's that option as well. And she's fantastic. So I could just start exploring a potential date for her to come during a public meeting for her to present to you. Okay. And with that, again, I'm gonna do my best. It has been, it's been a request from the governor's office in the state for the enterprise census, but anytime you all have a question, a comment, you want to offer any advice or connect me with someone, please, I really welcome that.
Sorry about that. So just because we are part of this broader, like a lot of times people think about like DEI as being like at the individual level or like the group level. But we're part of this overarching, the laws, the rules, the policies. I wonder about, so this is just a suggestion, and I don't know where to put it, but something around structural barriers, because I think that that is one of the things that if we can address that, that significantly changes inclusion.
100%.
Just gonna.
No, 100%. And one of the things to that is what were the structural barriers to keeping someone from serving on a board? What were the structural barriers for keeping someone from serving on a rack? And I know the structural barrier for having someone on board is often pay and taking time off. And so it was a very big conversation in the legislature of how we diversify boards and how we make sure that we make them accessible. And what we did here, at least in our rules, is vote on per diem pay for prep, but also there are so many structural barriers. And I think the one thing to add is the partnership I forged when I knew I shared you all on the invite, the screening of, thank you, everybody's work, working with Nurses of Color and University of Portland. That's going to screen Thursday after a very long 3 days together of board meetings, but I'm committed to going. I partnered as OSBN saying this is important. How do we partner to make sure this is screened and we're a part of it? So that was just like an example of how we make sure we show that we're going to, the board of nursing is showing up to partner in this way.
One thing on that note, since legislative session is coming up, has anyone thought this could be a cross-board thing about getting something along the lines of anyone serving on a government board would be released from work as a law that every employer would have to follow if someone's serving on a board or commission?
Yeah, and I don't know if that's been brought up at all. I do know that when I'm having conversations with people interested in being on boards, and this board in particular now, in my role now, it is really having and how to have those conversations with your employer, knowing that having them on, someone employed by you on the board, it helps everyone. So right now I know, it is part of the conversation I have, but I don't know about how that would work if anybody's tried to do that as a law. And I don't know if it would come up against what it would come up
I don't
against,
know.
but
It was just a thought,
Yeah.
because I know that's a big barrier for a lot of people is
yeah,
time off.
taking time
and-
off, depending on the level of job. But I do know as when I was a legislator, this conversation was a big one in a lot of spaces on how to make it more accessible. I just don't know if that part of it got brought up and what happened with it, but I can find out.
I was just thinking it'd be a good idea, especially for if we're trying to encourage people that are on the lower end of the pay scale or
Mhm.
that aren't in higher level areas to join different boards and commissions and
Mhm.
participate.
Brandy, can you go back to the strategic plan? I just want to, before we go into customer service for the next 25 minutes, can you scroll down to, I think it's towards the end, the timeline? Right here. So phase one was around this clarity, and really, again, ensuring that we had a mission, we had a vision, we knew our values, and we really were clear on what those were. And in phase two, focus and action, and really between now and the end of 2025 is what must be accomplished over planning horizon, what collective actions do we need to take to deliver on our priorities, and how will we measure success? And so I think these are the things that I am going to hold myself accountable to ensure that as we go through every step, I'm constantly checking in with you, constantly going back to figuring out how we meet these goals, and then what we're going to do to measure. Measuring success is measuring success to have impact is really getting at how we're going to start collecting data a little bit better. I think I know your board president and I just recently at National Council State Board of Nursing, there was lots of conversations around data and how to measure for impact. But I will commit myself to this phase two, and then way out there 26, 27. We can get there when we get there. Okay, can you now go back to where we get into customer service? And then I'm going to pull up a few numbers just to report out some of that data. Mhm. Thank you. So again, our strategic plan and our imperatives and what we had to lean into is really what the governor and the state enterprise as a whole has been tasked to do. So whether it's DEIA or customer service. So the statement is OSBN serves all Oregon citizens, and providing excellent customer service is a critical imperative. Your leadership team, and with your approval, talks about objective to improve our relationships with our customers. Strategies will be to optimize customer service are increase phone hours and improve phone technology, improve language access, and simplify applicant and complaint forms. So just to update you, I already shared with you, we're looking into tapping into language access. And we do have a available contract signed to ensure that during investigations, if anybody needs that we can offer that. And that is something new that we have incorporated, led by our investigations manager, ensuring that we did that. As far as the phone hours and improved phone technology, so let me just pull up the numbers of where we're at. So our, you know, when I arrived, we were off the phones for 4 years. So a decision made during COVID to pivot everybody to process license and get off the phone. That really impacted us and impacted our how we serve nurses applying for license, for submitting applications. So we reopened in January 22. It's staffed by one supervisor. We have officially hired 2 public service representatives. And we are open since January 22nd from 8 to noon. And your licensing techs back up the contact center depending on wait times. And October 1st, we are going to be expanding those hours to much more full-time contact center. We take anywhere from, let's see, when we first opened, we had 288 calls in the month of January. We peaked in July at, April at 1,489 calls. And in August thus far, when we measured this, we're at 1,366 calls a month. So you imagine how many calls we weren't answering over the period of time that we weren't on the phone, and why we had so many people upset. So I'm really proud of the work that our licensing department and our contact center is doing in that space. It's definitely impacted our application timelines as well, which is part of that customer service, because someone can get somebody on the phone to find out what's going on. The next step of the customer service is our licensing manager has identified how our licensing techs can be proactive and saying, this application started, but these pieces are missing, and let them know. Lots of times what we're having is an applicant not know what they're missing and not know they're missing anything and just wait and wait and wait. So then that timeline is extended and they don't know they're missing something. So we've identified a way to take care of that. With that being said, when we have everything, we now process applications, which is huge. Huge, huge. Yeah, so the average for application, and that's including all of the ones of not having, includes the average of not having all the information, as opposed to once we have it all, it's 3 to 5 days. Not having it, the average of the last quarter was 12 days. The average of endorsement was 18 days. And when I arrived, they were both 50 on average. So it's testament to the work that our chief of staff has done with our managers and our staff as a whole to really identify process efficiencies. And I will be presenting to the House Healthcare Committee Monday on these topics because they're very much invested in finding out from the nursing board, the medical board, the board of pharmacy, the social work board, and the mental health regulatory board, what we've been up to, knowing that our legislature and our governor's office heard multiple complaints from the different boards and the challenges that we faced. And now what are we doing to course correct? So I'm excited to go bring that information. So the second thing that we are really focused on in customer service is becoming a trauma-informed agency. So implement ongoing training and trauma-informed practices, ensure application questions are trauma-informed and free from stigmatizing language. So I think where this comes into play is we've had trainings for our licensing staff from on customer service. We've had trauma-informed training, one already for our investigators, another one coming up next month where I'm partnering with the Board of Physical Therapy as well as the medical board to have a training for our investigators. You'll get a training today from Victoria Priola discussing kind of that just culture, reimagining discipline, what that looks like. And as far as the trauma-informed application process, I know that in our public meeting this week, we'll be having a conversation around what the next steps of having the removal of our questions in the attestation model instead. And then moving into how we'll measure it. So focus on our key performance measures. And again, I just talked about what those are, is our surveys around customer service that go out to the public, as well as our application timelines. And I do have information because I'm presenting it to the Healthcare Committee on Monday. Let me open this up. Doo-doo-doo. Sorry. Oop. So pre-COVID, we were averaging around anywhere from 91% of satisfaction for accuracy of information, availability of information, staff knowledge, staff helplessness, timeliness of services provided, and overall satisfaction. Those are what those measures are. And I can send the slides out to you that I'm presenting to the Healthcare Committee on Monday. They'll be public for everyone to see, but I'll send them specifically to you so you have them. I just have a few finalizing touches before I send them out to you. But then we dipped down during COVID and then not on the phones, all the way down to in 2023, 67% for staff helplessness. So we are back up in 2024 to our pre-COVID rates with 86% of accuracy of information, overall satisfaction, timelessness of service provided. So we've really recovered from all of that time off the phones and getting everybody trained on how to help our customers. We had, we had Department of Revenue come in. They have an entire office on customer service, and I'm like, if they can talk about taxes and have it center customer service, I think that we can. So they came and did a training here. So, any questions, thoughts, comments, additions about what you hope to see here? Yeah, you, me, the legislature, and the governor's office. Let me see if there's any other information I want to make sure that I don't miss.
I was just gonna say, I really appreciate that proactive about like, hey, here's what you're missing. Because especially a lot of our licensees, it might be the first time and they just haven't gone through the process. And so this kind of alert, they're gonna get us the information, but it really serves them well.
Yeah, no, it's huge. And it helps everyone because we're not going to have hundreds, thousands of applications just sitting. Right, they end up expiring out, but they're sitting and then that clogs up the system. So how do we start this process? So our licensing manager has been leading on that, and I think we should probably be implementing it. It's working with our vendor for licensing orbs to make sure that we can get it done.
I think that we should be implementing in October is what I'm hoping.
Okay.
That's what I'm hoping.
So I'll report back on that. But yeah, because I can only imagine what those averages are going to turn around, right? Because when you know you're missing it versus waiting for them to call a month in, what's going on here? So, and then I guess just an update on re-implementing the 30, 60, 90-day reminders, which we had heard about. That's been huge also. So we're not seeing people not able to get their license and have late fees and all the stuff that comes with that. Part of a good customer service plan. Yeah.
Is that also for, like somebody who lives in Florida?
Yep.
and-
So our endorsement process, that's the average that is 18 days once we have everything. But yes, they will also be notified of what we have and what we need. And I'd say about that process, we were months out checking transcripts, and now we're pretty much same
come out.
day, same day.
And are they getting 30, 60, 90 day for their renewals?
Well, as soon as they have a license in the state, then they're treated as the timely reminders for renewal. So absolutely. But the initial application or the endorsement, those are the ones that are the 12 days and 18 days. But a renewal happens automatic in our system. If you're reminded and you do it on time. The only glitch in that that holds up is the OHA workforce data that you have to do to renew. There's sometimes up to 4 hours delay between starting your application then being able to go back to it for your renewal. And that's something I hope to prioritize and work on in the future too, of how we're collecting workforce data, OHA is collecting workforce data, how we, and it's important, but how we can improve on that. But I think with the 30, 60, 90 days reminder, you're having less people be like, oh my God, it's due today and I have this 4-hour wait and what the heck. So what the heck?
Question and a comment. One, I think these are amazing numbers because access to care is part of protecting the public. So yay for that. And my second question is, and just, I'm not a nurse, I don't know, do you require continuing education? And is that part of something they have to submit for licensure?
So that's a great question. And it's going to be something you're going to hear more and more talked about. Every state has different rules on continuing education and or clinical hours. And I think you'll see as we update Division 31, us leaning more into what other states are doing of CEs versus clinical hours. And with that, your presentation on Thursday is really going to talk about an opportunity for us to partner with an organization that kind of helps with that. As far as what is required right now, the only ones that are required by statute is our cultural competency test and our PAIN CE, our PAIN module. Those are the two that are required. But I think that we're going to start to see more of that shift to the way of CEs. Mhm.
Speaking of the cultural competency module, that's really dated language. Have we considered updating that? I mean, I took it probably when I started, so I haven't had to redo it. But I don't actually know what's in it right now.
Yeah.
But anyways.
So as the state representative who carried this bill on the floor for this, I have learned a lot now that I'm on this side of what it means when representatives or the legislature as a whole says these are the courses that are needed to renew your license. And again, there's conversations around, should we have suicide prevention? Should we have dementia? There's so many conversations about what we should have to renew. But at the end of the day, the research also shows that just because you take one course doesn't mean you have necessarily competency in it. And so I would say that the thing that I've learned is passing a bill, implementing it, and then having it constantly updated is an interesting thing. And Oregon Health Authority is really the lead on the PAIN module and the cultural competency. There are conversations happening around it, and your policy analyst, Sarah Wickenhagen, sits on that work group. And so there's lots of conversations on how cultural competency needs to be improved. And also, I think if we are leaning in and focused on CEs versus clinical hours, there's going to be more ability for us to then say, these are these courses that are offered to meet this. But right now, I would say there is a disconnect from when the law passed, the modules that are there, and what we need now. But yeah, it's, conversations with Oregon Health Authority for both of them, because you say that about cultural competency. I feel very strongly about the pain module not being updated.
Well, and as a different licensee, I think most PTs view those courses as what a pain, literally, right? Because typically therapists are taking 6 and 8 hour courses in pain, and now I have to take this other module too,
Mhm.
right? I think
Yeah.
PTs like to be more autonomous and choose what they want for continuing education. So we don't like seeing it directed from the legislature.
Nope.
Just a comment.
Nope. I agree. And I think though there is that, what are the topics that could benefit every single, in this case, nurse across the board, versus why should every nurse have to take this one? Anything else? Okay. Told you mine wasn't as exciting as our last one. Thank you, Kimberly. My number one fan and my cheerleader. So why don't I would suggest that the board president calls for us to take a 10 or 15-minute break, because we can get our lunch, we can come back, we can then have our lunch as we talk board governance, which I've given out kind of a one-pager to guide our conversation on that. And then you won't have to hear from me for the rest of the day.
We'll take a 10-minute break to grab our lunch and then we'll be back
Great.
at 12:35.
Thank you all so
All right, we are back. We're going to do a lunch and learn.
So, Mr. President, board members, we only have 15 minutes to talk board governance. So there's two options here, because at 1 o'clock we have a presentation. There's two options here. We can have this conversation. I gave you all handouts. It really is just me wanting to check in with you all of kind of, let's talk about board governance, and then are there things that you all are feel like might be missing. Again, I gave that handout. We could have that conversation for 15 minutes, or I could say we can discuss at another time and you can just eat. I thought I'd give you all the opportunity to decide. Okay.
All right.
And so board governance, I gave you all the handout. I'm just going to read from it and then really open it up to these kind of discussions. And if you wouldn't mind, Kimberly, taking notes in case there's comments from the board members. But so our board is responsible for protecting the public safety within the nursing profession. Your oversight ensures that we provide safeguards and boundaries, but we're also balancing that with asking what unnecessary barriers we have in our rules and how to remove them. We strive to enhance the nursing profession to the top of licensure while monitoring and evaluating patient impacts. The board's drive for improvement is essential in continuing to strive for excellence in patient outcomes, identify areas of appropriate application of nursing practice, and meeting our customers' needs, including licensees, nursing programs, employers, and the public. And as board members, your encouragement of discussion, use of focused questioning, and drive for action will continue to progress the nursing profession within Oregon. And so I kind of shared some suggested questions to just really initiate the board discussing board governance in general, and really help us achieve, kind of in a general strategic discussion around that. So the kind of questions I put out to you all about this is, if you design the agenda, what else would be on it? What do you feel like you need to know about our work that has not been shared? How is the external world changing in ways that are not reflected in our board conversations? What don't you know about the work of the board that you're most concerned about? What do you see always being discussed but never resolved? And what are you not discussing that you want to talk about? So again, those are kind of like really conversation starters, but to how to continually help me improve our agendas, help me ensure that I'm kind of following the guidance of the board when it comes to board governance framework. And of course, we can't do that in less than 15 minutes, have a huge, robust discussion on all these things. But if there's anything just really like you've been thinking about and you really want to share, as you just recently went through, pages and pages and pages, what potentially is missing. And I think we talked a little bit about some of the work that's happening to continue to expand and improve. But if there's something that hasn't been talked about, hopefully those general questions help guide a little conversation. Hmm. Yeah, and a reminder, I have been told that I'm really good at using the mic, but the board members aren't as good at using the mic. Sorry, I had to show there's one thing I got going on here good today. So if you could lean in a bit or bring it closer to you as we have the discussion, that would be great.
Okay, one issue, two areas that it applies, and that's kind of our treatment of cannabis. Where a nurse may, there's a provider order to administer cannabis for a medical condition, and there's lack of clarity if it would be within their authority as a nurse to carry that through, given the mix of like federal and state laws that they're contrary. I know that And I just kind of like chanced upon it when I was doing some other investigation. California last year had the same issue come forward, and they issued like a policy statement to give more clarity to their nurses around that. So that was one issue, is just like medical orders, where do nurses, what is our policy and perception?
So can I ask a question then? You all voted on the interpretive statement, so similar to probably the statement, how they describe them in California. Was there something missing from that? And again, then what do I would have to go back to, what are the statutes now? What are the rules now? What do we have? And then if there's something that needs to be changed on the statute level, maybe, because we did just do the statement.
So you're saying missing from our previous statement? Yeah, it didn't speak to that when a nurse has a patient that has a medical order or something that is legal in Oregon, but is Schedule 1 under federal designation, right? How do we reconcile that? Because the nurse is carrying out the medical order. So this isn't just like hyperbole, this is an example that comes to practice to nurses in Oregon
Yeah.
that I've heard of.
Yeah.
And also in California, which California, like I said, is a little step ahead, and they made a statement saying that if it's a medical order, it's, the nurse is able to carry out that order.
Okay.
Not face sanction. So that was one area, and just kind of how we want to see that, if we want to be ahead. Also thinking about, with federal changes, proposal to reschedule cannabis to schedule, and how, I don't know where that's at in the process, but there was talk that could come out this year after they do later this year. And so how we're kind of anticipating how we might change some of our internal policies and the ways that we treat cannabis. So, and then the second issue is related to having a licensee that is on probation or HPSP for substance use disorder, and how we treat cannabis. So some of the literature is evolving now, that it used to, and it's still a common practice. So if somebody has opiate use disorder, and they were to use cannabis on the side, just like someone would use alcohol, and maybe they don't have an alcohol use disorder, but they do have cannabis use disorder, or they have, opioid use disorder. Do we, in our probationary practice, treat it as just like a failure of their treatment, or is there something that's more nuanced that takes into account the literature that, I was reading big meta-analysis, because it applies to my day job, about if someone has opiate use disorder and they have cannabis in their drug screens, that it is not predictive of failure or rather, return to use of opiate. And so just kind of how we're treating that. I don't know what our precedent has been with probation. It actually hasn't come up in any of the cases that I've seen this year, so maybe it's not that big of a deal, but
Yeah, so I think just in this format, what we can talk about is, one, we were at a conference on a national level. This is a conversation. And I do know that there's precedent for one case here that potentially we can discuss at another time. But I think as far as I guess I'm looking for the big question is a discussion. I will say we get hundreds of questions in our practice box to our policy analysts, and whenever questions are brought up around cannabis, I share a Sentinel article that was written, and I share our recent interpretive statement. And I think that what you're asking for is to potentially explore the conversation that's happening on a national level when it comes to the what word am I looking for? The controlled substance, rescheduling of the substance, and how that is going to impact boards of nursing as regulatory functions as we look towards our own policies and procedures. And yeah, okay. Gotcha.
So this is something I've been thinking about, and honestly, it's something I've been thinking about for 15 or more years, because I've seen it as an issue. Education person, right? Here's Claire. And basically, and maybe there is history of this. I haven't ever noticed that even if there are multiple letters from other programs that a nursing program is ever not approved. So I'm curious then why we go through the process of approving them, period. Why we ask for notification if we're not going to do anything about it. And I actually don't think I don't think we should remove all approval processes. But my concern is that things have gotten 15 years ago, it was like, wow, we don't have, we're at max capacity. And we're way past that now. And we continue to approve programs. And I get that it's I mean, I've heard like, what is our scope? Is this getting into like competition, business competition? Like, we don't want to limit that. But I am curious about, I would like us to discuss this because I think it's a huge limitation for nursing education. And I'm very concerned that what's going to happen is that students are just going to have less and less opportunity to be in the clinical setting. Because if you look at you can always get letters like, we're so excited to have your students, even if they have students from 6 other locations and they're denying placements at those locations. So I'm wondering, like, if we're going to have them go through this process, is there ever a time that we deny? And what would that look like? And then just being, I guess, thoughtful of what our process is, because I think this is about protecting the public, is having graduates who are well prepared.
So I think today you'll have a presentation by, policy analyst, Laura Blackhurst. And then, of course, these conversations are happening on the Rule Advisory Committee, Division 21, but I took note of that also.
And if I remember right, in that Rule Advisory Committee, we're also talking about, or it could be a different one, if they continue to not meet standards, what areas the board, or what rights the board have, what ability the board has other than just revoking their approval,
Right.
because that's not fair to the students, but that's currently the only option we have for schools that fail their surveys, is to take away their approval.
Right. And there's been more conversation about how to find that support.
Right.
Yeah. So in the last few minutes, I'm really thankful for these very specific examples, and want to put out that I was also thinking very high level kind of things that might be lacking, that in every board packet you're seeing, that maybe I need to make sure I keep an eye on to support you better.
More of the facts in like our discipline cases, it's getting better, but there's still some of the, according to John Smith, blah, 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 instead of laying out the facts. I mean, some of the might just be old cases that are making their way through, but a lot of the formatting is becoming.
Yeah, we're definitely standardizing more and more, and getting closer and closer to.
But it's definitely helpful, and it's just, this is the fact of what we can prove. And then they can add like, we interviewed blah, 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 and this is what person A and B said, and later on, but we need to know the specific facts is very helpful.
Last one.
I actually feel like I've been finding the facts more after they put all of that at the top. Then you go back to summary section to say, here are the facts that we can prove. Here's what we know. And then please provide direction. And I like it that way, because then I could get the whole background and the whole story behind and imagine it. And then go to like, all right, what exactly did you find? Substantiated, and what did you not? And then they do put like, oh, we could not substantiate this, or we could not get this, and then just provide this direction. I like the way it is now, although it seems longer. I like the background story because I am able to take out, if I feel like there's any bias in the tone, I can take that out, but I can read it better. In opposed to if you just give me a summary, then I feel like I don't get the full picture of what happened in the background.
Well, and the goal should have the goal should be to remove the bias in the first place, and that's another thing that we're definitely working on.
100% agree with that
Mhm.
because I just want the facts. I don't really want, well, I do, but I don't want to rely on just the investigator's interpretation. Right? Because there may be some bias in there. I don't know. Maybe there's not, but I want to read the facts for myself because I think that's my job.
Okay, so we will continue this discussion. I've written down some notes on making sure that we lean into a little bit more. And now, I want to move on to the next agenda item. I'm really excited for Dr. Victoria Priola to present to you all.
Can everyone hear me?
Yes, we can.
Great. Can someone say something so I can adjust my volume?
Yep. We can
There.
hear you.
Great. And you can
We
see
can
me?
hear you. Welcome.
Great. And you can see me?
No, unfortunately, we can't. And I don't know. I just recently learned how to present in Teams so they see me and the presentation, but maybe, oh, yay, there you are.
I'm a quick
Great.
learner. Quick learner.
Thanks, Brandy.
There we go. Hi, everyone.
Hello.
Okay. Rachel, did you want me to just jump right in or how do you want to?
Yeah, jump right in, do an introduction, and present. And we're all just finished lunch and ready to learn.
Oh, no. Are you ready to learn or are you sleepy? Hope you're not sleepy. Well, hello, everyone. My name is Victoria Priola. I'm a clinical psychologist, and my work has primarily been in the law enforcement, education, and healthcare sectors as I bring psychological tools to those organizations and individuals to help them sort of work smarter, not harder, and use psychological principles to inform their work for better outcomes. I come to you as a daughter of a law enforcement professional and a nurse. So I share that with you because some of the things that I talk about today you may be aligned with and maybe you're not. And both of those things are okay. I'm here to provide a perspective that is certainly part of what I've learned over the years of my work intersecting with these organizations and professions, but also wanting to share sort of the trends in the literature. So I'll share both of those perspectives so that in the end, hopefully what you'll take away is some information that you'll use to think about how you might infuse some of these concepts, ideas, and research findings into your own work as regulators. So I'm here as a supporter of your work. I'll open the presentation with some goals that I hope to accomplish and invite you to have a very relaxed approach to our conversation. If you have questions or concerns, feel free to just go ahead and interrupt me and ask. And I'll leave plenty of time at the end so that we can process together some of the things that I talk about and answer any questions. So the first goal that I have for our presentation today, I thought of about 30 and I was able to narrow them down to 5, wanting to talk specifically to you about how nurse wellness, that's physical, emotional, and cognitive wellness might be considered as a variable when you're determining whether or not a nurse is safe to practice. I'll spend some time providing some evidence so that you will have support in appreciating how and why nurse wellness has most recently been linked to public safety. And we'll talk about the role of mitigating factors as a tool for supporting you in determining the appropriate board action that you might take, regardless of the nature and extent of the case as it relates to mental health and wellness factors, in determining whether or not you can support them in returning to work. I think it's important for us all to consider whether or not public safety and nurse advocacy can be done simultaneously within the regulatory framework. There have been quite a bit of needle movement on the physician side, and also quite a bit on the nursing side at other boards that I've traveled to and spoken with. So kind of wanting to ask you to take your own temperature about where you stand in the dialect of those two things. It's public safety and nurse advocacy, meaning well nurse is a safer nurse, and what role regulators can play in that process. As I said just a minute ago, the hope is that, unfortunately, I'm not able to tell you specifically what to do with this information. I leave it to you to decide what you want to do and what you can do within the structure of state law. So let's just jump right into it. There are many reasons why regulators might want to consider or need to consider wellness as a variable in determining whether a nurse is safe to practice. But one of the first things that we know for sure, and that bears out in the literature, going back decades, of course, is that the healthcare landscape has dramatically changed. Most notably since the 90s and the advent of managed care, but certainly since during COVID and since then. The nursing profession and healthcare professionals in general, as you well know, have been forced to work in under-resourced environments with limited supplies, often under dire conditions, that result in the kind of moral conflict that healthcare workers experienced sort of in mass units in the military, for which, regular nursing school or typical nursing school, certainly in the US, really has not prepared them to do. So certainly the landscape of healthcare is a factor that we have to consider. As a result, the biggest problem is that nurses are reporting a significant decrease in their well-being overall, but particularly with regard to their mental health. As a result, we're seeing an increase in many boards, not all, but many are seeing an increase in their recidivism rates. And consequently, many nurses have stated that they've had enough. They're leaving the profession. So much so that when the National Council of State Boards of Nursing conducted their most recent national nursing workforce study in 2022, they're about to come out with another one in 2024. They found that respondents reported an overwhelming level of stress and burnout. And as a result, the NCSBN put out an urgent call to action and said, look, we've all got to work together to figure out how to promote a more resilient and sustainable and safer U.S. nursing workforce. Many organizations on the national level, you may be aware of, have answered that call. The first of which was NASM. And sorry. Having a little trouble on this end. 1 second, please.
Much better. It's perfect now. Thank you.
Okay, thanks. Indicate that nurse wellness had the potential to impact the entire healthcare system, so that they put out this acknowledgement of the connection between nurse wellness and overall functioning and safety. They indicated in their study, and I've included a resource list that I hope that you've received already, so you can check this study out for yourself if you want. That patient perception and the experience of the quality of the care received went dramatically down. That individuals who access the same resources in the healthcare systems in their communities were noticing that nurses that they had connected with previous visits were no longer around, that there was a tremendous cost of retraining that these healthcare facilities were experiencing that decreased the level of care and the overall pleasantness of the environment, not to mention that nurses, when they were leaving these environments, were taking all of their organizational knowledge with them, creating a sense of a lack of safety, not just for patients, but for their coworkers. And that this affected the overall perception of the public of their trust in the nursing profession in general, which Gallup polls, you may or may not be aware, have consistently rated nurses the highest in trustworthiness out of all healthcare professionals. The American Nurses Association also joined the conversation with findings from their 5-year report, highlighting the fact that they found that the health of U.S. nurses is often much worse than the average American. As a result, they've launched all kinds of initiatives for physical, emotional, even financial well-being, and that they were trying to connect nurses with resources in any way that they could to increase their overall wellness, particularly with regard to mental health and substance abuse. The American Nurses Foundation joined in and said, yes, we too recognize that nurses experience an extraordinary level of stress and that it absolutely affects their mental health, their well-being, and subsequently patient safety. So they too have put out a number of resources for nurses to access to improve those limiting factors. Many of you may be familiar with the Lorna Breen Foundation. Dr. Breen was a ER physician in New York during COVID who took her own life. Many of her friends and family members put together a call to action that resulted in the Lorna Breen Healthcare Provider Protection Act, and they've set out a mission to help advocate for a world where seeking mental health services, particularly within the healthcare professions, where seeking mental health care was considered a sign of strength, and that they were trying to fight against the stigma that many nurses and healthcare professionals experience when they're struggling in these environments. In the regulatory context, we know that the Federation of State Medical Boards put out a statement in 2024 saying that they felt that medical boards had a duty to protect the public and that they had a responsibility to ensure physician wellness as one of those measures. They also felt that there was that boards needed to make efforts to minimize the impact of policies and procedures, sort of along the lines of administrative burden that many healthcare workers talk about, that negatively impact their ability to feel well. They have an expectation that boards collaborate among all stakeholders to support ill and impaired physicians, and that they made a specific call out saying that physicians should be able to access care, mental health care in particular, without any fear of stigma or bias. So one of the things that I learned about as I've been traveling the country talking about wellness to various boards, groups of healthcare workers and individual nurses in my private practice is that not everybody shares the same definition of exactly what it is, particularly as it relates to the healthcare environment. So a person can feel well in their personal life, but not necessarily feel well within the healthcare environment. And it's a very curious thing from a psychological perspective as to why that might be. I found that many people talk about wellness as the absence of illness. And while certainly that on some level might make some sense, I think it's important for us to know that that's not the entire picture. So when we think about a well nurse, we have to think about it from a holistic perspective within the context of where they're working and spending most of their time. So a well nurse is a nurse who can accurately assess their knowledge and skill So they're not flying above their station. They have a verbal and behavioral commitment that they demonstrate to the practice of the ethical guidelines that guide the practice of nursing. They have a feeling of positivity about what they do and their ability to do it well. They have conditions at work that support the quality of that work. They have a sense of feeling, I guess, a commitment or a duty to cultivate and maintain positive work environments and help everybody out, and that they feel the ability to thrive and achieve their full potential in the environment that they're working in that feels meaningful and fulfilling to them. So as we move forward with this conversation, I hope that we can consider that perhaps in the past there were 3 variables that we looked at when considering whether or not somebody, how to respond to a regulatory violation. That were they knowledgeable? Were they skilled? Were they ethical? And now we're adding this other piece. Are they well? One of the ways that we think about wellness, or try to at least assess it in some sort of systematic way, is through the consideration of mitigating and aggravating factors. I don't know if you have a policy or a procedure in place already for considering these factors. I've learned that some boards don't. So I thought it would be worthwhile for us to talk about exactly what they are and how they're used. Mitigating factors, of course, being evidence and information that you use to decrease a sentence, and aggravating factors being those things that might increase. I provided you with a sentence. So I provided you with a couple of handouts. Do you happen to have those in front of you? Could anyone say something?
They're getting to them now.
Okay. So I
Page
just
29.
provided. Okay, so I provided you with some resources that you may find helpful as you process the information that I'm sharing, specifically about mitigating factors as they relate to the law. The Federal Public Defender's Office down in Missouri put together, and they're always changing it. So I encourage you to hop on their website if this is something that you're interested in, because the links show the different forms and worksheets and things that they have developed to help them sort through the process of mitigating factors, as well as aggravating factors, and all of the components that might be useful to explore. It's very, very extensive, and I just want to be clear that the suggestion here is not that you need to go to this extent in order to be on board with the idea that a well nurse is a safe nurse. We're wanting you to be exposed to the kinds of information that's out there so that you can begin to think about what kinds of questions you might ask your investigators to explore.
Victoria, can you hang on just one second?
Sure.
Yeah, so I had just sent out her article in Focus, but she did also email resources, but they're not in your packet right now. I think they were sent afterwards. I really don't think they're in there. They're not in mine, and they were sent afterwards. So they were forwarded to you via email. So I just don't want you guys to continue to look through your printed stuff and not the presentation because they were emailed to you.
Are we good?
Yeah, I just didn't want them to continue to look through while you're presenting. So you can go back to the presentation and they don't have your stuff in front of them right now, but
Yeah,
that's
that's
okay. They will have them in their email and look to after.
Yeah, that's fine.
Yep.
Yeah.
Thanks.
So, so that's one resource that you might find, and you might find it a little bit overwhelming and wonder, oh my gosh, how does this apply? And certainly, that's a appropriate reaction because there's a lot of information there. But again, just trying to kind of get your juices flowing to thinking about how you might incorporate some of these ideas. The other piece of information that I shared as a resource is information about the Douglas factors. Is anybody in the room familiar with the Douglas factors? Can you just raise your hand if you are? Nobody. Do I see Ella?
Nobody, it'll be all new, fresh information.
Okay. Do I see Ella sitting back there?
You sure do.
You must know about the Douglas factors, but I won't put you on the spot. I wanted to just introduce this idea because it's a wonderful resource, again, to be thinking about if you were interested in exploring in more detail what mitigating factors might look like in your work as a board. This is a 12, one pager with 12 guidelines on it to help you sort through whether or not it would be useful information for you. But the goal here, it's used at the federal level. Their guidelines used to determine the outcome of employee misconduct cases. So the goal is to take a look at the interplay of these factors with the specifics of the case in order to respond in a reasonable, proportionate, and fair way. So just as a point of clarification, because this came up a little bit with your investigators and certainly has come up with other boards as well, just wanting to make sure that we're clear that my position here is that I'm not sitting around thinking about ways to convince boards to excuse a nurse for their choices by exploring mitigating factors. I'm not looking for you to think about how to give them a pass. What I'm asking you to think about is how you might thoroughly work with investigators to get all of the information you need to help explain and understand the violation so that you can certainly respond fairly and reasonably, but also so that we can maybe play a role in preventing recidivism by making decisions that are more targeted to the individual's issues and concerns. Another resource that I provided you is from the North Carolina Board of Nursing, and they put together this kind of nifty, they're calling it a complaint evaluation tool, and I'm sure you have your own. But the reason why I included it in this discussion is because they did kind of a nice job on the back side of it, indicating mitigating factors on one side in like a check the box kind of way. It's like a little worksheet, as well as aggravating factors. And they kind of walk you through what those things might mean in terms of what response would be required. So I hope that you'll take a look at that later too, to see how you might integrate it into your work. I think I covered all that. So one of the things that I just wanted to make sure that we were clear about as we move into more of the psychological component of this conversation is that sometimes once you've identified mitigating factors, what you realize is that you've bumped into something that is beyond the scope of your own personal expertise. And that sometimes, particularly with mental health, we have to tap into the to them to help us make decisions about what the data we collected actually means in terms of outcome and answering the referral question of whether or not an individual is safe to practice. One of the things that I've discovered in these presentations and conversations is that mental health seems to be something that is still largely misunderstood. Lots of misinformation about who does what, where, when, and why, and how that logistically plays out is that boards are sending nurses for evaluations to individuals who may or may not be qualified to answer those specific referral questions. So unfortunately, we aren't going to have, the amount of time that I would love to have in order to go through what each of these experts contribute to regulation and to board responses. But suffice it to say that it's very important that whatever the referral question which is hopefully something to do with whether or not the individual is safe to practice, goes to the right person. So a psychiatric evaluation is very, very different from a psychological and certainly from a neuropsychological evaluation. And the quality of the information and the relevance to your question around safety will be largely different as well. What we're looking for, and of course I'm a psychologist and only psychologists can conduct psychological evaluations that are standardized, objective, and subjective as well. And we don't make medical determinations. We do diagnose, but we can't provide recommendations for medication, which may or may not be relevant at the stage that, or with regard to the kinds of questions that you might want a mental health professional to answer at the point that you're interacting with the nurse. but it's important for you to appreciate that a well-defined and very clear referral question affects the quality of the information you get, as well as the selection of tests that the professional uses. So creating some sort of relationship with trusted professionals, psychological in nature, will certainly go a long way in helping you create the kind of environment where the quality of the data that you're using to make decisions is something that is reliable and valid. Along those lines, one of the intricacies of the mental health expert has to do with being able to understand that many of the conditions that you might be concerned about in relationship to safety are on a continuum. And so assessing risk, for example, about stress, and whether or not it's traumatic stress or whether it's a function of typical and expected stress, is something that's best left to a professional. The reason why I say that is when someone says, well, I'm just so stressed out and I'm so burned out, that's become part of the pop culture vernacular that has a very different meaning from in a clinical perspective. For example, did you know that when a person comes into the hospital after a traumatic event, whether it's a psychiatric facility or a general hospital facility, it's very likely, let's say a car accident or an assault or something of that nature, that immediately they're going to be experiencing symptoms of acute stress disorder, which is there in the middle. Acute stress disorder looks and sounds and smells like post-traumatic stress disorder, and is often misdiagnosed that way because most people are familiar pop culturally with PTSD. There's been enough buzz around it. However, there's an exceptionally big difference between post-traumatic stress disorder and acute stress disorder in duration and in whatever the trigger was, so that a person will resolve from acute stress disorder within a month or so. If it doesn't resolve, the symptoms persist or worsen, then a person after that 4 to 6 weeks time period is diagnosed with PTSD. It's important that we make a distinction further between PTSD and something called PTSD-C. PTSD can arise out of one traumatic event or a series of traumatic events, but not necessarily chronic, where the PTSD, the C stands for chronic. So these are individuals that live and breathe trauma. It's part of their lifestyle. It could have happened when in their early life, it could have culminated at another point in their life, but the complexity of that particular disorder is much more difficult to treat and requires many more resources and experts to help that person function at what might be an optimal level for them, but significantly suboptimal when compared to typical or average other adults. It's also important to note that just because a person experiences trauma does not necessarily mean that they carry a diagnosis of post-traumatic stress disorder. One of the things that we've learned and that was really solidified post-COVID in the healthcare professions is that trauma itself is not the thing that we need to worry about the most with humans. What we need to worry about is what happens in response to the trauma. That becomes the biggest indicator of whether or not a person will develop any psychological diagnosis that's stress related. So this speaks to the overall goal of the presentation and to what all of these various national organizations are saying, which is, yes, people in healthcare, nurses are exposed to trauma, but our response to it as supporting entities, organizations, individuals, and groups is that we need to do a better job of validating and supporting them in the experience of their trauma so that it doesn't exacerbate and they leave the profession, or worse, they stay in the profession traumatized and their functionality is decreased significantly, leading to concerns around safety. Just in case you were wondering whether or not trauma and PTSD is a problem outside of the healthcare industry, you may or may not be surprised that it is quite the problem. Most recent NIMH studies have found that three out of about 50 Americans suffer from PTSD, and that women suffer from it more often than men. Studies, including the one that I've posted here about the Advisory Board 2023, found that about 30% of the nurses that they surveyed reported some symptoms of PTSD, not necessarily the full-blown diagnosis, but certainly symptoms, which has led many researchers and national organizations to wonder if PTSD is something like akin to a second pandemic. In taking a peek at the nurses and other violations that are most commonly reported, we find something pretty interesting in relationship to trauma. So hear me out on this. These tend to be, and I wonder if you agree, and perhaps we can talk about it when I'm finished, tend to be the most common complaints or violations among nurses. And that when we take a look at the symptoms of trauma, we start to see this interesting connection emerge and integration. Judgment, time management, a lack of empathy, emotional dysregulation. These kinds of things tend to show up or can be pretty related in that very linear kind of way to some of the symptoms or some of the violations that are more common that boards hear about. And so it really begs the question, are these individuals demonstrating violations of the Nurse Practice Act or the Ethics Code because of some sort of character or morality problem, some knowledge or skill problem? Or are they having these kinds of issues and being brought before the board because they're suffering from some sort of mental health condition that's been largely untreated and undetected? It's also important to know that even though we have a very clear idea of what trauma looks like, there's also significant variation in the mental health world in terms of how an individual experiences psychological distress. For example, trauma sometimes looks more like depression than it does when you start looking at the DSM and saying, well, they don't have this, they don't have this, they don't have that. But we understand, those of us in the clinical world, understand that when the brain experiences trauma, the first thing it does is shuts down. So when someone awakes after experiencing a motor vehicle accident, say what happened, and they don't remember. So depression in the body and brain shutting down after a significant trauma is a pretty common thing. Sometimes people carry the diagnosis of depression and the trauma is assumed but never treated. So the point here is that we have to be alert to the way these things are individually experienced and do our due diligence to make sure that we've identified what the real problem is. It's also important for us to know that even though trauma is a commonly experienced disorder among mental health professionals and certainly nurses, everyone benefits from trauma-informed care. The root of trauma-informed care in the clinical sense, of course, has everything to do with not making assumptions about what the person's experience is or how it's impacted them. So being open to hearing about what their experience is and responding in kind. We also know that when we miss trauma, when we misdiagnose it, or when we just simply ignore it, that we're putting nurses at risk for worse outcomes and potential recidivism. So here's just some more statistics that you can be interested in. And I think you're going to have a copy of this. So if you wanted to go through it, you're more than welcome to. But in the interest of time, I'm going to keep going here. One of the complicating factors that you may or may not be aware of is that a person could have, say, a major depressive episode that they're working through at the time of the trauma that they experience, right? And then on top of that, they could have another condition like ADHD, some intermittent anxiety, or a personality disorder. So we start to get a real appreciation for the complexity of the mental health issues that could be at play in any individual, but certainly in individuals who have come before the board due to some sort of violation. I wanted to talk for just a few minutes about something that you may have experienced quite often, but not known or how to put your finger on it, and that is personality disorders. Regardless of whether the person is suffering a co-occurring disorder, like a personality disorder or something else, I just want to make sure that everyone is clear about the expectations of treatment. Recovery with mental health does not happen quickly. It's a complex condition that's got roots in all avenues of the person's life and existence, and it requires a tremendous amount of support and integrated care. Lots of barriers exist to people getting better. If they have other health conditions that are physical that they're battling, if they live in environments that are particularly stressful or difficult, like a substance abuser who lives with a bunch of alcoholics, going to have a much more difficult time recovering. So we have to set our outcome expectations in connection to the realities of their lives. The cluster B personality disorders are what I want to spend some time talking about with you now, because I have a feeling that not one of you has been lucky enough to avoid experiencing one of these individuals personally or professionally. Personality disorders are different than the clinical conditions of depression, anxiety, trauma, those kinds of things. So those are experiences that come from outside of the world and land on a person. Personality disorders exist from within the person. They are chronic, maladaptive patterns of thoughts and behaviors that form the personality itself. They are highly unpleasant and difficult personalities to be around. They have a lot of trouble forming relationships. Maintaining relationships are certainly very difficult for them. They are not collaborative in nature. These are individuals who are sort of like my way or the highway, and they set up all sorts of obstacles and difficulties for people who do not subscribe to that idea. In general, the 4 cluster B personality disorders are considered to be the most severe of psychological disorders, in that they tend to have a very low sense of shame, a very low sense of empathy or remorse for the negative impact that they have on people. And they are intensely unpredictable, very dramatic, and very emotional. And they use drama and instability and their emotions to manipulate and to control the narrative. These are the 4 cluster B personality disorders that you may have heard about or experienced, that I would strongly advise you to learn a little bit more about, so that you can sort of recognize what you might be feeling when you're in the presence of an individual who might be suffering on the continuum. Again, these are also on the mental health continuum. They may have traits or they may have the full-blown diagnosis, but the impact that they have on you is largely the same. Of the 4, the narcissistic personality has probably gotten the most play in recent years, since social media like TikTok and Instagram have tons of information about people who are living with narcissistic abusers or who fear that they are narcissists themselves. By the way, if at any time someone would say, gosh, I wonder if I'm a narcissist, that's a pretty telltale sign that they are not, because narcissists do not have that kind of insight. And if they did, they certainly wouldn't admit it. So you can appreciate that when you look through what I've got up here on the screen, you can appreciate that these are individuals who probably don't fit the mold for what you would think of as a successful healthcare provider or nurse. The problem with cluster Bs is that when they wreak the havoc that they wreak, they tend to not admit it. They blame other people for the trouble that they create. And they say, well, if this person was doing their job or that person wasn't mean to me, I wouldn't have to have done what I did. So it's always about somebody else. They typically do not find their way to treatment unless they are encouraged by someone else or forced to go. And once they're there, they tend to talk about other people being the source of their trouble. And if the psychologist or therapist or psychiatrist could help them change other people, then they would get better and not have the problems that they have. So these are individuals who have very little interest or capacity for accountability, and they have very poor therapeutic outcomes. So the reason I'm sharing this with you is because as we talk about wellness, these are individuals who are highly unwell with little motivation to get well. And when you're working with them in the regulatory context, that's the worst environment possible for them. So they tend to be very angry, very hostile, very self-righteous, and sometimes dangerous. They'll be uncooperative and untruthful, and they will always frame their violation as a reaction to somebody else's deficit. And that's kind of a red flag. So what's important for you to know is that, let's say you take into consideration all of the things that I'm talking about today, you start thinking about and prioritizing nurse wellness as a public safety tool, and suddenly a individual with a cluster B personality disorder comes across your desk, and you all your best efforts to just culture, do all the right things, you follow whatever is reasonable and fair, and the protocol is top notch in terms of implementing what is right and good, and these individuals will not respond to it. And you might think, well, a lot of good all this just culture and nurse wellness stuff does. Look, this person is, still having the trouble, and they're recidivating, and they're doing all these things. I want you to consider these people outliers, because they're not typical. Even though there's more people who suffer from a cluster B disorder than we originally thought. We used to think it was 1% of the population. Now we think it's somewhere around 10%. So it's much more common than we thought. But it can help you understand and appreciate that despite your best laid plans and the most earnest of efforts, the response that you create for them in terms of their violation likely will not work. It's because these conditions are very, very serious. It requires lots of intervention from very specialized experts. Because these people are rooted in significant distortions and very resistant to help from others. So it's wise for you to consider them as outliers and seek support from evaluators who have specialization in personality disorders to help you figure out how to manage them. So one of the questions that came up with some of the investigators when I presented with them is, well, what should I do with this information? Why is this helpful to me, and why does it matter? And I think one of the things that I'm hoping that you'll think about is that even though there are legal variations from state to state about what boards can and cannot do, as I said at the outset of this conversation, and even though I can't offer you specific guidance on how to integrate this information in your policies and procedures, I still think that there's tremendous value in joining this national conversation and momentum about nurse wellness and public safety and advocacy and regulation, so that you can think about not just what you're comfortable with individually as you evaluate these cases and make decisions, but what kind of culture you want to have as a board as you think together about what next steps you want to adopt. I also want you to know that I appreciate that this is an exceptionally complex thing to try to tackle, and that it's very important to me, so that I'm available to participate in whatever conversation you decide you might want to have, or any other conversations that you would like to have related to mental health, to help you determine what this information might look like in your role. And I'm going to do something to prove it, and provide you with my contact information, so that if you have questions or concerns, complaints, criticism, that I'm open to hear about it as I continue to be part of this call for duty to support nurses in being safe and help patients and healthcare organizations along with you promote the safety for the purpose of protecting us all. So I thank you for your time and I open up the room for questions.
Thank you so much for that presentation. I'm still shocked that you share your phone number in this space as well as in the space where I met you and 400 people were listening. But yeah, let's open it up. And I just think as Dr. Priola mentioned, I think it's really important that we keep it very general. We're not going to dig into anything specific. Every state is different. It's really here to like plant the seed to really continue that growth conversation, thinking about the topic. But while we do have the person that is really, leading this conversation nationally, I think it is a great opportunity to ask questions or have a conversation, but just remember nothing specific about what we do in our other sessions. And then just remember to turn on your microphone and maybe introduce yourself to her when you ask your question or comment.
My name's Aaron. I'm the board president. I'm also CNA. I'm actually going to school for psychology with hopes to eventually get my PsyD degree as well, because I want to focus on helping healthcare workers specifically
Right.
with their mental health. I was surprised that there's so much movement out there in the world supporting healthcare workers, because we just started recently in the last 6 months moving towards nurse wellness as being patient safety or public safety. I'm really happy to hear there's other states and federal programs working on the same thing. Other board members?
Nobody else has a comment or question. I am stunned. There you go.
I really appreciate this. My name is Claire McKinley Yoder and I'm one of the board members. So thank you so much. I just was thinking about the piece that you were talking about with people not like there's a certain group that is not going to be whatever disciplinary actions we take and we consider mitigating, they're not going to be happy, but also they're going to be more likely to have issues in the future. Is there, so I guess with that, is the idea then that we should kind of bank on the fact that we're going to have some, no matter how trauma informed we are, we're going to have some folks that it's just not going to work for.
I think that's right. And I'm working on a project with Christopher Peters at the University of Wisconsin-Milwaukee as we try to think about how to address this problem before it gets to you. And we've identified perhaps some changes in the use of criminal background checks and the way people interpret that information getting into nursing school. Right. So in law enforcement, which is a large part of my work, we require people to first take a civil service exam, and then we require them to do a fitness for duty evaluation prior to us inviting them into the police academy. Then if they have trouble while they're in practicing, being technicians of the law, we'll call it, and they get citizen complaints or, they become a public safety risk themselves, then we fitness for duty them again. And then we fitness them, if we decide that they're going to stay in law enforcement, then we fitness for duty them again after treatment and before we release them back to work. And so Chris Peters and I are thinking about, and I understand, and he does too, all the legal ramifications of a process like this in nursing. But raising these kinds of questions about, are we thinking about criminal background checks the right way? And is there another tool that we could use when issues and concerns arise once a person has criminal background checked and has been accepted into nursing school, or perhaps has contact with the law during nursing school? Do we address that in any way? If so, how? So that perhaps down the line, that component might not ever come across your desk. So yes, there are certain people who are not going to respond to whatever efforts you offer to support them in returning to work. And I'm not exactly sure, because I'm not a regulator, what boards should or could do about that, but it is certainly a point for consideration. I hope that kind of answers your question.
Yes, thank you.
Hi, my name is Linda Stanich and I'm a board member. I've been a nurse for 33 years. I think the one thing that really brought something like massive to my thinking is when you had said, what about a second pandemic? And the reason that that kind of comes to the forefront for me is 33 years ago, we all just went about doing our jobs and so forth. Never thought that obviously when COVID came about, we all started off strong. We ended up kind of sinking in whatever was going on. But now having this in front of us, I actually think it's wonderful, because what if we are hit with that second pandemic? So I appreciate you kind of bringing that just thought to my
Yeah,
thinking.
you're welcome. And thinking about all of the nursing professionals who worked through the pandemic, were expected to behave in heroic ways, were given pencils and pizza and whatever else as acknowledgments of their putting their lives on the line for the sake of all of us, who are now walking around traumatized and untreated, and trying on their own to recover from that, which is not a good thing. And certainly pencils and pizzas are nice, but certainly not enough to help these people get returned to their previous level of functioning, if that's even possible. So that's a really important component around our duty, our ethic as the public, in my opinion, this is my opinion, to talk with boards, regulators, and hospital administrators about how we need to do much better by these people. We owe it to them. And that's my personal opinion.
Other board members?
Victoria, I thank you so much for presenting a full day with the investigators and an hour with the board. I respect the work that you're doing so much. And, one of the things I keep thinking about when you said the second pandemic is what we have learned as a nation and a world from what happened, because it could, what if it happened again, and we haven't recovered as a healthcare profession, as somebody who stepped down after it. And every time I think that I am, I then have there's a conversation like this, and I have, kind of go back to that space of everything we went through. And I just am committed to working with this board and taking their guidance as we figure out how, regulation in the state and across the country starts to really think about this. So thank you. And I did share the resources you shared, and you can follow up with her anytime because she gave you her information. So, but yeah, I thank you so much, and I'm sure you'll hear from us again.
Thank you.
Thank you.
Thanks for your work, everybody.
Thank you.
Bye.
All right. So just a little update. I know we have 2 policy analysts between 2 and 3. Gretchen is sick, so we'll just have a presentation from Laura Blackhurst. So maybe take 5 minutes and then I'll grab her so she can come and present to you all.
We'll take a 5-minute break and be back at 2.
Great.
Don't forget to turn your mic on. We are back with our policy analyst, who's going to go over some high-level overviews for us.
Yes, hello, Mr. President and
You don't
members
have
of,
to hold these ones.
I don't?
No, we have new fancy.
They're awesome.
Oh, that is amazing. Okay, I love this. Well, good afternoon, Mr. President and members of the board. Yes, I am going to be presenting some really high-level policy information about nursing education programs. I forgot I've already control of my PowerPoint. So the topics I'll be covering are really brief overviews about some of our rules for nursing education programs. I'm going to speak to the NCSBN model rules, what those are, what they say, and some of the national trends we're seeing in nursing education. Thank you. And a really brief overview of how we handle complaints about nursing education programs. So to start, really wanted to start with just a snapshot of Division 21 has all of our rules for the LPN, RN level nursing education programs. And so every one of these bullet points represents a rule we have in place for these programs. And so you can just kind of see at a glance, there's a lot that we have standards for regarding education programs. You'll notice in the left-hand column, a lot of the rules are really process-driven type rules. So how does a new nursing program become approved? How do we periodically evaluate it? Skipping down a little, how do we deny or withdraw approval? And at the bottom of that column, how do you close an approved nursing program? So a lot of process. On the right-hand column, we have more of our rules and standards for some of the function of our nursing programs. And so this is where you can find rules for everything from what has to be in a nursing curriculum, what do clinical experiences have to look like, who can teach in a nursing program, what are the faculty qualifications. And then the one thing that's maybe a little different within Division 21, all of these rules really pertain to our Oregon-based nursing programs. So I'm referring to programs that physically operate in Oregon. But our final rule, which I'll talk a little bit more about today, is related to out-of-state nursing programs that maybe have clinical here in Oregon. So that's Division 21 just at a glance. Division 51 is where you can find our rules for the advanced practice nursing programs. So one thing you might notice immediately is just how different the number of rules are for these two divisions. So there is some history behind this. The rules for our APRN programs, these programs must have that national accreditation, which we've discussed in the past. And so national accrediting agencies have standards for a lot of the things you saw listed in Division 21. It's just that those programs in the past did not need national accreditation, and so we were providing the standard. So that's why maybe you see such a discrepancy in the number of rules. We are continuing our work to streamline our rules for all levels of nursing education. We are working really actively on Division 21 and with our advisory committee. And our goal is really to bring in a lot of the Division 51 rules. Realistically, institutions that have an advanced practice nursing program often have RN programs as well. And so we really want to unify the standards so that these schools aren't looking to two different parts of the Practice Act for like instructions and guidance. So that is our two divisions surrounding nursing education just at a glance. I'm going to take us to looking at national trends and really what is happening in nursing education outside of Oregon. So I'm going to share some information with you that you have already heard from me, but it is still the national trend in nursing education, and so it's still very relevant. So when we look outside of Oregon, we really try to have a consistent process for how we are looking at what is happening. So the two big things we think about when we look outside of Oregon is we look at the National Council, their model rules. And so this is an evidence-based regulatory framework. What that means is that the National Council has already developed a full rule set for different levels of nursing education, again, based on evidence and research often that they themselves have conducted. And so there are rules that we can potentially kind of pull over and use here in Oregon that have this evidence-informed framework. We look at those. We also, to look at our national trends, we do have a large number of resources through NCSBN. So we get annual reports about all the different boards around the country and specific to education. So what are they doing for nursing education? If we have a specific question we're interested in, we can conduct surveys, send out our specific questions to the different education reps at different boards of nursing. And then sometimes we really just want to look at the practice acts of different boards and see, what is the wording they use? How do they address this issue? What is their process? And so again, we really try to be consistent in the review we're doing. So pretty consistently, I am looking at every Western state and their practice act. One correction to my image is I look at the states. I did not look at Guam, but Guam was on my picture. And then there are a couple of states more on the East Coast that have regulations kind of similar to Oregon, or even statutes similar to Oregon, or well-developed nursing education rules, and sometimes we'll look at them as well. So we're looking at a large number of states to really compare Oregon against. The theme as we do this work is, again, what are the national trends in nursing education? What barriers are we noting? What is Oregon maybe doing differently that maybe there's no evidence to do that, or maybe there's a better way to do that that's clearer for nursing programs. So I have 4 different areas where, going through this process of looking to NCSBN and looking at other states, where we're identifying some differences that are opportunities for us to maybe improve our rules. So the first one is our rules around approving a new nursing education program. So the NCSBN recommends a 3-phase process for how you review a new program. I have little check marks there because we have these 3 steps in our rules. Where Oregon maybe differs a little bit from what NCSBN proposes is that we have a 5-step approval process. We have a letter of intent, step 1, that I'll speak to in a second. We also have a developmental application step that would fall between the preliminary and initial. So looking at how NCSBN approached the issue, they really merged what we do in the preliminary and developmental steps. And one of our goals is to get us to this 3-phase process. And we're also seeing that a number of other states are already there or working towards getting there. Really the biggest difference we found when we looked at our process versus national trends for approving new programs is that we have a letter of intent process where it is step 1 of wanting to start a new nursing program. Are you a year prior to wanting to launch a program, are having to send a letter to all of the approved nursing programs in the state, all of the chief nursing executives of potential clinical sites you might be using, and then the board is collecting feedback on that letter of intent. So it's a really a formal step in our approval process. I could only find one board that required evidence of public notification, but no boards had this formal letter of intent step in the approval process. I also could not find any evidence when I looked at all of these different boards that boards were collecting feedback about potential new programs in considering the approval of a new program outside of the existing venues for public comment that already exist at public meetings. That is something where we've got an extra step that it looks like a lot of really none of the other states really have that step. Just one having something where there is a public notice required. That is all I'll say for now about the approval process. The next area I want to highlight for you is enrollment and admissions. So again, I know this is another topic I've spoken to you about in the past, but the NCSBN model rules we're finding they don't have any guidance on the regulation of enrollment or admissions for nursing programs. When we look at the other regulatory bodies specifically, lots of different things. There are some boards that are reviewing a program's admissions or enrollment, up until it gets full approval. Some states are looking at enrollment and admissions when that program is like first approved or on survey. A couple states with really specific rules, like if it impacts clinical sites or faculty to student ratio, the board wants to hear about it. One state had a really specific, if there's a 20% increase in your admissions over 3 years. But the small majority of 8 states said there were no rules for enrollment or admissions. And so I think more commonly when we actually look at how other states are thinking about admissions and enrollment to their nursing program, they're actually more looking at does the nursing program have adequate clinical resources? So we don't necessarily need to hear the number. We need to know that you have enough clinical resources so that all of your students will have placement. The other big difference we're noting is that, again, other boards are really doing that at initial approval of the program and anytime we're re-surveying them for their continuing approval, making sure, again, when we're back on site, that, again, they have adequate clinical resources for their students. So I'm calling it to our attention because, again, this does differ from some of our process here. We do have nursing programs notify us if there's an increase or decrease of 8 students in their enrollment. And then we have historically tied that increase to programs needing approval to increase their clinical resource usage. All right. The next thing I want to talk about is looking at model rules and national trends. We're finding some differences with faculty qualifications and clinical ratios. So I'll speak to faculty first. The model rules state that a faculty should be academically and experientially qualified. So it does not specifically identify a degree. It does not specifically state like what that experience is or a number of years experience. Nationally, really most states want that nurse educator to have a master's degree. But when it comes to the experiential qualifications, there are some differences we're finding. So in the bottom left, in Oregon, the green is a little harder to see on this PowerPoint, but Oregon is the only state I could find of the ones I reviewed that requires 3 years of full-time patient care experience. So we already get a lot of questions about that rule because, what does full-time mean? Lots of nurses work part-time or half-time or per diem. So how do we calculate our experience? Our rule says patient care. And as we know, lots of nurses do not work in patient care roles. And so that is potentially a barrier. And then again, just comparing to other states, there are some states where they're requiring either 1 year of nursing experience, 2 years, Or we're starting to see states adopt the NCSBN's language of the faculty just need to be academically and experientially qualified. And even a number of states that have no statement specifically about qualifications. One thing to keep in mind as you're reviewing this is that, again, we are planning to implement rules where nursing programs would have to have accreditation. And so accreditation, they are going to be very interested in the qualifications of faculty as well. And so they're often, looking very closely at the faculty and their CVs and their CEs and, how are they actually qualified? And so for a lot of states, they are able to adopt more flexible rule language, such as academically and experientially qualified, without having like a really concrete number or 3 years full-time patient care experience. Then I want to speak to clinical. So the NCSBN model rules, again, are really flexible. Clinical experiences shall be supervised. So NCSBN does not have an evidence-based recommendation on what that specific faculty to student ratio should be. We require 1 to 8 currently. And so again, when we look at other states, the 1 to 8 is our green, kind of a sad green, the green color. But actually 50% of the states I reviewed are using a 1 to 10 ratio. And then another, like more than a quarter of these states simply just don't have regulations. They don't state anything about what the faculty to student ratio has to be. So Oregon is, not alone in being at that 1 to 8 ratio, but we are in, the smaller group in this chart. And so that's another thing that we are looking at, again, especially as we have faculty shortages. If one faculty is able to supervise even just 2 more students in a group, that can help support being available for our nursing students and having faculty available for nursing students. The last thing I'd like to talk to you about in terms of trends and model rules is going back to this out-of-state nursing program topic. So the NCSBN does not have model rules on this subject either. Approvals for programs that operate out of state, those programs must be board approved in their home state. So the NCSBN does not have any guidance on a board approved program out of state coming into your state and doing clinical. Nationally, it is really hard to identify or describe a trend here. So what I am finding is that every state is doing this differently. And, to that end, each state has different statutes. So those boards may have more or less authority to regulate this because, again, this is effectively an out-of-state program with just students doing a clinical experience in state. I am finding that sometimes the approval process for out-of-state nursing clinical experiences depends on the level of program. So sometimes you have to get approval if you're bringing RN students, but not APRN students. In some states, it's flipped. And so just for reference, in Oregon, if you're bringing LPN or RN students to do clinical in Oregon, you get our approval. But last June, we repealed the rule for the APRN out-of-state programs. So those programs are not needing approval to operate clinical here. So again, really hard to describe a national trend here. It looks like every state is doing things very differently. Processes are more and less intensive, including, some states where you're approved in your home state. It's fine to do clinical here. So this is something that we're going to be digging into a little more, getting even more details about to really understand the landscape here, and look at how we can improve our rules if that's what we see we need. All right, I am going to move and change subjects on you again. So I am going to speak to handling complaints regarding nursing programs. So Those look like broccoli. I wanted to kind of give you an idea of the type of complaints we get in the first place, because I think they're probably very different than the complaints you're getting about like scope of practice. So here is just a snapshot. So sometimes we see complaints about teaching practices, everything from I don't like how my instructor teaches to concerns about exams or assignments. We hear complaints about clinical experiences. These can be I don't like the policies for clinical. I feel like I'm unsafe in clinical. I don't have a faculty watching me in clinical, and I'm concerned about that. Student policies. So, there are a number of policies that can really impact a student's admission, readmission, progression, dismissal. And so sometimes we hear complaints about those policies in those programs. Curriculum that can include everything that's in the curriculum and everything that's not in the curriculum that maybe someone is concerned should be. Um, Workload and staffing. This is really relevant for both faculty and the administrative staff in a program. Sometimes we hear complaints about the workload is so much that I don't have time to actually educate my students safely, or we don't have enough faculty to actually operate this program. And then sometimes we get complaints about incivility and bullying. This can be faculty to faculty, faculty to student, administrator to faculty. So all different, scenarios that can occur in a nursing program. So when we get these complaints, we are triaging them. And we do think about, is this a complaint about the program, or is this a complaint maybe about the individual licensee in the program? Because potentially there is something that's maybe more related to the standards for nursing practice versus the standards for the nursing program. When it's a nursing program, if it needs investigation, it requires a program survey. So when we hear a concern that seems like this is something that could be an issue that we want to understand further, if this is an NPA violation, we really need to go to the program. We need to talk to people at the program. We need to look at records at the program. And so really only the board can authorize a program survey. And so when a concern comes up that after we've triaged it, we think that, this is something we want to look at, that is something we bring to you and ask you if you think that a survey is warranted. If you do authorize a survey, across the bottom is our process. So that survey would then be conducted. Whoever conducts the survey will develop the report and present the findings to you. If you, as the board, determine that yes, there is a deficiency with one of the standards we have for programs, then you would authorize us to provide a written notice to that program of where they're deficient and really a timeline for them to correct that issue. And then ultimately, either the program will correct it or they will not. Beyond that, those next steps I really are, does the program address the deficiency? So that is all I have for you today. Like I said, it was a very fast overview of a lot of different subjects. So I'd love to take any questions you have.
Board members, any questions? And this is just kind of the broad overview. If we want to get into specifics about a certain topic, we can get it on the agenda for a later time, but keep it kind of general about the overview.
Hello. You had mentioned, we have talked previously at this board about making all programs in Oregon accredited. What kind of discussions are you having about that now? And do you have a timeline laid out?
That is a fantastic question. Thank you. So we are definitely having discussions out with the community. We're hearing, honestly, a lot of positive feedback. I will be truthful and say that it's not all positive. People are concerned in some places about like the cost and the resources needed for accreditation. But I would say the majority of the conversations that I'm having are very positive. People really understand, I think, the value of accreditation, that it's raising the standard and the quality of nursing education. And I think a lot of the public can really see that when you do that, you make the public safer, you make our graduates safer. So, positive mostly. And then in terms of a timeline, I would say that's harder to say. We want to make sure that as we are updating the rules that, we are being really transparent with our RAC and the community we're working with and making sure that everyone is on board with the changes as we're making them.
Just one follow-up to that, and sorry, I'm learning the mic. Are there, I mean, when we think about accreditation, are you already thinking about certain principles that you would follow? Are there other states that you're using as examples or?
Yes. So we do look at, there are a couple of other states that, there are a number of other states that are already requiring all of their nursing programs to be accredited. Washington is a great example of a local state that requires this. And so it's been a really positive benefit that other states have rules in place that have been tried and tested, that we've been able to look to their rules and figure out how to pull those over to the ones we're drafting and make sure that we're aligning to our statutes as we do it.
Would you mind if I added to that? I think you shared with me when we were discussing it that currently is it 65% of states or 65% of schools are already accredited? I'm sorry.
I
remember?
believe it is 61% of states already require it, and 65% of our programs already have it.
Thanks. And I think when, just to reiterate what Policy Analyst Blackhurst said about the timeline. So as you know, Rule Advisory Committee 21, as I shared earlier, how we're keeping it very transparent and open and large. That means lots more of lively debate. But at the end of the day, she brings to you all the discussion. You all decide on what is the right thing to do for public protection. And so that is, as we say, we're always looking to show why we're doing something when we're in our racks, but that doesn't mean everybody's going to get there. And that's okay too.
Would you update me on which national accreditation bodies are we considering?
So our goal is to allow any national nursing accrediting body that is recognized by the U.S. Department of Education. So to name a few of the common ones for RN and LPN level education, we're looking at agencies such as, oh gosh, I know my acronyms, but
LN is one of them, maybe?
the NLN's CNEA, their accrediting arm. Yes, we're looking at them. We're looking at CCNE. ASIN is another one for RN and LPN level. And then our advanced practice programs, some of them can use those agencies or look to specialty agencies for depending on which APRN program they're offering.
Pretty widespread of
Yeah,
different national accreditation bodies.
our goal is to be flexible and supportive of nursing programs. And so they can identify the accrediting agency that maybe best suits them. And we would allow that. But again, it still has to be an agency that still has USDE authorization. So there is some level of security to it.
You choose. The question I have is back to the nursing students, obviously to the instructor, and 1 in 8. I'm going back years ago. I'm old. I'm thinking of, and I wasn't from Oregon. I'm thinking of how I got through clinicals. Not sure, but I see the benefit to the 1 in 8. because of obviously the time that they're going to have. The two questions on that, the one where you said there's not the number of the, could it be 1 in 2 on, I forget what the percentage was on there. Could it be more, like 1 in 20? Is there anything that you have on that? The second part of that question is, what would be the disadvantage, or would we entertain, and maybe Claire, you can chime into this, to the 1 in 10?
Those are wonderful questions. So I think I'm going to address that question first. What is the disadvantage? And I think the disadvantage is always as an instructor who is managing more students, there's more going on. There's more that ultimately you are making sure your students are delivering safe practice. So I think that is a big disadvantage. And then admitting that, an instructor workload is often, there's more to it sometimes than just, your work on the floor, that these clinical instructors are responsible for evaluating the student and grading assignments. And so it does increase the workload of the instructor potentially when you increase the number of students they have. One of the things we're looking at, and again, some of this is coming from what we're finding in other states, is that there are states that have really flexible models for this faculty to student ratio. And so one of the things we are discussing with the RAC is, what about a model where the faculty who is truly supervising the student stays at that 1:8 ratio? But if the faculty is not the supervisor, because maybe a student is working directly with the nurses in that agency for the shift, could that faculty member actually maybe take 12 students, a little bit more? And then also calling out that when students do a precepted experience where they are working one-on-one with a nurse, could that group be even bigger? So we are looking at something that maybe allows programs a little bit more flexibility. We're also hoping to call out in the rules a bit more explicitly that nursing programs need to make arrangements with their clinical partners. Like this can be something that a nursing program who has a clinical partner has some understanding or arrangement of what level of oversight is needed of these students and what's an appropriate ratio. And also highlighting for nursing programs that when you are making these assignments and thinking about ratios, you've got to think about the level of student, what they're working on, and the level of acuity of the patient. And so, we are, I think, wanting to still have some ratios in place as like a barrier to protect safety, but also again letting it be a little bit more flexible and also dynamic for schools and their clinical partners. Did I answer everything? Okay, thank you.
A huge part of me appreciates the flexibility part of it, just because I've precepted nursing students in the first year, and being available to see their strengths and weakness, they appreciate it later when they graduate. It's like, hey, I see you succeeded more in this aspect of nursing versus here, and helping them find that balance. It's amazing because I feel like I've seen every single person I precepted. I work with as a clinical instructor in their first year, and seeing them now. The one I said maybe ER will be fine for you went there. The one I said labor and delivery started out med surge. The yellow that she saw me, she's like, yeah, I moved to labor and delivery. I didn't like med surge. And it's like, it's nice, but when they have that one-to-one experience directly with the nurse in their final practicum year, it's different because that person can give them that support, in opposed to if you're not there for everybody, there's always that one or two people that might just retract and not participate as a group because they're just not open to talking. And we have to look at cultural differences and different backgrounds of, we don't talk where I'm from, so I'm just going to listen to instruction and do my base. But if we're able to do that flexibility, it's
Yeah, thank you for that. And I think one of the things that we are continuing to affirm is, regardless of the clinical ratio, whoever the faculty member is still ultimately is responsible for evaluating that student, making sure they're meeting the course outcomes, program outcomes, making sure ultimately big picture that they are safe in clinical. And so yes, hoping that flexibility can support nursing programs, but reaffirming there are some roles for the faculty here in ensuring safety of these students.
Thanks for the presentation. You didn't speak as much about advanced practice RNs, but I kind of have two questions I'm wondering about with looking at the national landscape and what's happening with our changes here. First, like how many so Oregon is in the midst of our sunsetting out master's prepared advanced practice RNs. And we're kind of sort of in the middle of the different categories of advanced practice RNs. I wonder how many other states are taking that approach. And that's the first thing. And then the second one is really as we're in the midst of the sunsetting, what that effect is going to be to our workforce and our demand for those programs. I would see as a student, generally the pay is pretty similar if you're DNP prepared or master's prepared. That would push for a demand for the out-of-state programs because you would have one less year of education. So I'm curious if there's much metrics or what we're keeping to kind of, especially since we're not doing that approval process for out-of-state.
Yeah, I really appreciate that question. I don't know that I have a specific number to give you, but one thing I do know about, our other states taking this approach, I would say, yes, this is the trend. And the evidence for that is that, again, these advanced practice nursing programs have to have national accreditation to operate, at least in Oregon and in a number of other states. And most of those programs are being pushed to offer doctorates instead of master's degrees. So I do see that more states are kind of making that push as well in their advanced practice programs. It's harder to speak to the impact on, at least from my lens of the impact on like the healthcare system. We are seeing a number of programs out of state that do have their students doing advanced practice practicums here. And I would say it is a mix of what level they're at. This one's harder for me to answer. I don't know if you know.
I don't know, but the answer is we'll get back to you. That is always the answer when we don't know, because it's I'm sure a conversation that is happening on the national level, and where is it we can figure out. Because yeah, I'm sure it is.
Well, and I'd just like to say that I do know that DNP programs they continue to increase year after year, like the number of applicants and graduates. So I don't think that is slowing down at all.
Thank you. I'm taking notes and I will research this topic for you.
Anybody else? Any other questions or comments? Thank you for the very quick overview. It was actually pretty thorough for as quick as it was.
I appreciate you saying that. Thank you very much.
I'm going to make one last comment, and it's I think when we zoom back out of what Oregon State Board of Nursing does and the conversations we have in our Rule Advisory Committee and engaging partners across the state, you also then have the layer of the legislature. And I've had legislators reach out to me and say, hey, why is Oregon 8-1? Can we change it to 10-1? And I say, I can't tell you all what to do if that is something you want to prioritize, yes, and we can have the conversation. But what I think is great is that we get to do that in our rules and have this flexibility. And so I let everybody that's reached out to me to know that the board is already having these conversations. So is a law needed? We'll see. So we'll see what happens in session next year if we come up with a better solution that then they don't fight for a law to just have it be 10-1.
All right. Thank you. Believe that moves us up to our
Okay, I think we're ready.
Yeah.
All right. Good afternoon, everyone. Sorry. There, I'll be my louder self. How about that? Good afternoon, everyone. I am really happy to be here today, and being the last presentation, I think it'll be quick and easy, and these good things about legislative overview with our session coming up. So we'll get started. All right. So some of this we're going to start out, it's really, very almost civics 101. But just to remind everybody, we have two chambers in our legislature, the Senate and the House. The Senate is 30 members elected to 4-year terms, while the House is 60 elected to 2-year terms. Every Senate district has 2 House districts in it. Upcoming session is going to be a long session. They happen every odd number year, last 160 days from January to June, and there is no bill limits in long sessions. That in itself is a massive undertaking. If anyone has been involved with legislative session, no bill limits, big deal. Short session is even number years. Oh, I hit the wrong button. They last 35 days. And there are limits on the bills and usually on the focus during those shorter sessions, although increasingly that's not necessarily the case. Legislators are limited to 2 bills in short session, and that makes it a lot easier for staff to be focused on what they're reviewing. We're gonna get I told to see what we saw in previous long sessions, so you can kind of get an idea in an upcoming slide. OSBN's role in the legislative process, we are part of the executive branch. And so that means that we follow and support, the governor's policies and budget positions. Our role really is to provide expertise and objective fact-based information when asked to do so by the governor, or if we have a legislative request to present. And ultimately also advance OSBN's mission to protect the public. So when we're providing that information in the lens of that. Dates in the upcoming session that are important to note. So all agencies work with the governor's office and legislative council to have legislative concepts that are drafted. We have received our initial concepts back, and we're currently in the process of having edits done. So we should be getting the final draft in the upcoming weeks. You should be hearing more about that. The dates that we are really focused on right now are January 10th through the 13th. That's going to be legislative and organizational days. And during those days, that's where you're going to see that first reading of all of those bills. It'll be the initial bill drop, and we'll have access to see what everyone else has been doing. Usually it'll be, 1,300 bills or so in a long session. So that'll happen on January 13th. January 21st is when the session actually begins, and we'll be off and running. I put down constitutional sine die, just so everyone knows. Sine die is the last day of session. And since we just learned it's 160 days, they haven't officially said the number, but I looked to see, and I think it's going to be June 29th. Don't quote me on it. That is the constitutional sine die, and they can end early if they would choose to. There will also be a target sine die. Additionally, I'm just going to note a lot of times during session, we might be following a bill, and we also have deadlines that are not on this list. There are things like work session deadlines, and that's just for a bill to get out of a chamber. If it doesn't make that deadline, we call it dead. But sometimes, you might see people getting concerned about a bill, and in effect, it's dead, and we don't have to worry about it. And we'll start talking about those dates as we get closer to session. This slide does not want to sit on the thing, but basically what you see here is a document that's actually comes out of the Oregon legislature, and it's used to explain the process of how an idea becomes a law. I think that I found it really helpful because it kind of has a little bit more detail, even though it looks like maybe you would share it in a school, but I love that they do it. It really talks through whether and how we move through, and it starts with, the idea and the concept moving from a legislator or an agency or a statewide elected official, moving into the legislative council and being drafted, being introduced and read for the first time. You'll see this sometimes you have first, second, and third readings. The first reading just means that it's introduced in a particular chamber. And then it's assigned to committee. The committee chair can choose to have a public hearing. That's where you will hear testimony and maybe have some educational materials available around that bill. And then they can choose to have a work session. Sometimes those happen separately, or you only have the public hearing. And sometimes they happen together and you'll have them both happen. It goes all the way through that process. It moves back to the floor. It has a second hearing, which is notice, and then the third hearing where they vote. If it passes that chamber, it moves over to the other chamber, and the whole process happens again. Right. So if it goes over to the second chamber, it has the whole process again. If it's amended on the second chamber, this is a caveat, y'all, it has to go back to the original chamber to be voted on again. It's a big deal. Once it passes through, let's say that we've gone both through both chambers, what you'll end up having is you get both the Senate president and the House Speaker to sign it. It goes to the governor, and she can sign, not sign, or veto. If she signs, it becomes law either January 1st of the following year, or if there's a prescribed date within the bill. If she doesn't sign, it still becomes law, or she can veto, and we can have it go back for a 2/3 majority vote in both chambers to override. I don't want to do that. Yeah. So there's that. So this is when I was talking about we would get into what these draft requests look like in a long session. So I put the numbers in two different ways because I think that they both really illustrate something. What you see is drafts requested and then measures introduced. If you go back in time, right, to 2017, you see 5,096 drafts requested. Only 2,829 bills were introduced. It's still a massive number, but we do have legislative counsel just cranking things out. Like it's a lot of work for them. And then you can see how many amendments are drafted for those bills. And I think really telling is also the measures enrolled. So of all of that work that's happening, all of the agencies and all of the legislators, everyone's reading these bills to see if there's things there that we need to be concerned about. And we're only having so many bills. An enrolled bill is a bill that's passed and is now going to become law. So we're having very few bills actually move when you think of the bigger number move on. It's a lot of effort. Huh?
Seems like they do less work each year.
Well,
They finish less work each year.
so we're passing fewer bills, but you can see the drafts requested are higher. It means
As
that they're
director
just
for
passing
SEC
fewer
law.
bills. Yeah. So all of this is to say, when we go into this session, our policy analysts are going to be reading a lot of bills. And that's a lot of work on them. So I'm going to thank them in advance. And say if you hear of something and you think, oh, they probably know about it, tell me anyways. I would love to know more because we're talking thousands of bills. It would be easy to miss something. So, all right. Any questions on that? Silent. To that, I mean, like it's a lot, right? So I wanted to give you all a little bit of, I can share these slides with you. A little bit of how to read a bill, mostly not because you have to read bills, but because sometimes you run across them and you really want to understand what you're looking at. You might have noticed on the previous slide that I had mentioned measures drafted rather than bills. And that's because we have 6 different types of a measure. Bills just happen to be our most common that we run across as a bill. What you see here now is that a key. So at the very top, next to the box 1, you have legislative session and year. And that's really important when we're looking back to see, you might hear somebody say, well, House Bill 4136, and they don't give you a year. Well, every 2 years we recycle numbers. So we'll use it over and over. It's really good to know what year we're talking about. That's helpful. Number 2 is the measure number. 3 is the sponsors. That might include things like whether it's an agency bill. And so, oh, well, No. I could have used like 4003 right off the top of my head. But here's the reason why I didn't. Is that this particular one, I had an example of every single thing on the first page. And that doesn't always happen. Okay. I'm like, oh gosh. Okay, so sponsors, and that can include statewide elected officials, so like at the request of Bully Commissioner, the summary noted here right next to number 4, right below it, there's always going to be a summary at the top that gives you a little bit about the bill. One caveat is that if it's a very big bill, it won't include everything. So just reading the summary is not going to tell you what the bill actually always has. And sometimes you get a little bit tricky there because there's more things there than what you see. A relating to clause is next to number 5. Relating to clauses. And I know. Well, here's what I want you to know about relating to clause is that sometimes people see a bill and they think, oh, well, we can amend any bill to do anything. That's not true. It has to be germane to the relating to clause. And that's the only reason I pointed out. Sometimes it's important to know whether or not a bill can survive past something or be gut and stuffed, which is a different term I won't get into. In the weeds. Yep. The big ones for you all is that plain text is existing law, bold-faced text is new law, and italic font in brackets is law that's existing that's going to be deleted or proposed to be deleted. I think that those are the 3 main things is that when you're reading something, so like 7 is an example of brand new language that's coming in. This bill happens to be about relating to tax credits for rural nurse educators. So you have bold new law and you have italic law that's being removed down by where number 8 is.
Question for
already-
you.
Huh?
So which bills starts with Senate side, which bill starts on House side?
So all bills start based upon where the legislator introducing them is. I think with the exception of revenue bills that have to go on the House side, like bringing it. So they have to start over there. Yeah. Any other questions? Yeah, that's in the weeds too.
No.
Happy hour.
Happy hour. So this is just some tips and things to note. And we just talked about additions and deletions, which I note with bold in my brackets. And understanding the context of the law that exists as it is now. But also looking for critical words, vague words, or directives. So like may versus shall, something like within available resources. If you're a board member and you're looking at a bill because someone's brought it up to you, those are things to note. And then also, sometimes an ORS may not be called out, but still affected. And that an example might be if some statute refers back to, say, a definition in another bill. So like if that changes and it's called out, it may not be noted in the bill and you would just be aware of it. One of the best websites, I think, during legislative session is OregonLegislature.gov. You can get through to bills, legislators, committee members, watch committees, and so you can focus and watch through on things. Also calendars. And one of the subsections there is OLIS. It's the Oregon Legislative Information System, where you can look up bills yourself and you can use keywords. So you might type in the word nurse or you might look for our statute. So 678, if you're interested in particular statute. You can also look at previous testimony, fiscal statements, different things like that. And it's really helpful. We're going to go next to what that looks like. This is front page of legislative homepage, OregonLegislature.gov on the top. Number 2 there, it called out is the different tabs and things that will be helpful for you. We're going to go to 2 things on this page. One is OLIS, which we'll look at next. And after that, we're going to look at the top line there where it says bills and laws. So Senate, House, bills and laws. We'll go there. In OLIS, you can look at current bills or previous years. So if there was something that previously existed, you can get to. And in the bills and laws, that's a really easy way to get to current statute. So a list will look like this. It has a space where you can get to the different dates. So if you wanted to review a floor vote and a previous date, or you wanted to go to a previous date because there was a hearing that day that you want to review, it's there. There's those second, first, and third readings. So if you happen to know that something was voted on and you want to see what was said, that's where you can see that in boxes 2 and 3. And then at the very top, there's box 4 with bills. That right there is going to be incredibly helpful if you want to just go and look to see what's going on in the current session in any language. If we went back to that homepage and instead clicked on the bills and laws, we'll find right here, over on the left-hand box, you can see ORS 2023 edition. And that's where you can find the revised statutes. I'm going to note that at the very top here, you're going to see that statute is only printed in odd number years. So 2023 statute will not include the short session statute for 2024. So you have to read 2023 and the bills from 2024 to know what the current laws are. We had an example of this past session with a bill that amended some requirements around the 90-day exception rules that we have, or exception law. And so that's not yet reflected in the 2023 statute, and it'll be printed again in 2025. So what about rules? We are going to be talking in more depth later this year on rules specifically, but what you see on the screen right now is actually the definition of what a rule is according to Oregon. And I want to point out one thing that I think is shocking sometimes, and that is that rules carry the full weight of law. So when we're writing rules, we're actually participating in law. And they are meant to, in essence, implement or be the directive of what statute is. So it's basically what is given to us in statute, and we go ahead and write those rules to implement or to tell how it'll work out for our agency. They must be consistent with statute. All of our rules must be consistent with statute. The reason that I'm thinking that rules will be a good conversation later in the year is as we go through session and we start to see what's going to come forward, we'll have an idea of what kind of rules we're going to be looking at. When we're looking at rules, every administrative rule follows the same order of chapter, division, and rule number. Each agency has their own chapter. Sometimes you see multiple. I think OHA has multiple, but I can't remember them off the top of my head. And so does DAS. I think they have one for PERS. They have, yeah. So if you see rules elsewhere, you will know based upon the chapter. Rules are compiled by our Secretary of State's Archive Division. You can find rules as they are currently, and this is going to be like the most up to date for our rules, by going to the Secretary of State.oregon.gov and going to Oregon Administrative Rules database, where you're going to be able to walk through, and you can go through and you can see every agency's rules there and how they overlap with us. This is going to be your best place to find current rules. I think that's it. I'm trying to stay out of the weeds.
You did a good job.
Any questions?
Questions? Comments? Bring it on.
What is, like, how will we interface with this as a board?
Right. So part of that OLIS site, it allows you to, I'm gonna see if I can go there. You can go, I'm gonna get there so that you can actually see it. Where it says get involved at the top, it has a lot of information on how you can review things, how you can submit testimony. I am also happy to, chat through and figure out how you can interface there. One thing I would say is that as a board member, if you were to testify as an individual, you got to remember to take off the board hat and put on, the Claire hat and say, and be very clear about that in testimony.
Well, and that was kind of my question. So as a board member,
Uh-huh.
I won't really have much. I mean, we'll be kind of all watching what's going on because this will impact our work. But it's not like we will, as a board, be doing any sort of,
Lobbying.
yeah.
No.
Okay.
Well, so if I may, so OSBN has submitted, 3, bills to be drafted. They are ones that were talked about, previously with you all. We have a technical fix bill because of our statutes are very outdated. We have a bill to discuss membership, and we have a bill to discuss HPSP. So those are the 3 of how you will see myself, Kimberly, potentially policy analysts engaged in the legislature on behalf of you all to speak to the statutes that are impacting the work that you do. The second part would be once the laws pass, and the reason why Kimberly and myself and policy analysts will be busy monitoring all of the bills is what ones are going to impact the board and where do we need to show up to make sure they have the data, the challenges, would it cost money, kind of lean into it in that space. And then once they do pass, be prepared to either implement the law and or set up rule advisory committees for those spaces that we have the flexibility or have been requested in statute to do rule. And then when we update our statutes, the further work of updating our rules to get to where we need to be. And then the last piece about Kimberly mentioning about specifically each board member, I can think of an example of a contentious bill that was passed, and there were 2 board members from this board who both presented, and they were on other ends of each of it, but they were there not in the position of a board member, but in a position of either their role as an administrator, or their role as a CNA, or their role as, so we have to be very careful of what our role is as a board member and what our role is when we're not representing the board, because you can't actually go and testify and then also say your name and your position on the board for something that isn't us, because the agency isn't, when I go now, it's not about necessarily my opinion, it's about data and
Right.
how it impacts the board.
Okay, so that's what I just want to clarify because I have done this before, like, and so I just wanted to, if I did want to speak to something, I don't say, hi, I'm Claire McKinley Yoder, and I'm not here as a member of, like, I don't say that. I don't need to even discuss that. I just wanted to make sure, like, being on the correct side of things.
Yeah, you would just never use this title as part of the testimony unless you were going because I said a board member from OSBN should really be there to represent the board of OSBN.
Yeah, I think that it's just about being very clear about who you're representing when you're there. Yeah.
So the changes we made to, I think it was 51 and 71, the RAC proposals.
You all have recently voted on 47 delegations, 63 CNA. And you've had discussions around 21 for education, 31 for licensure.
Will those go through this process?
Those are rule changes, and so those go through the Secretary of State Archives Division.
Okay.
And then they're reflected in the Secretary of State website.
Okay.
Yeah, so the first step is the statutes, then we find out about what changes were there. We then go, how are we gonna update our rules based on that? Or what we're seeing is we wanna potentially update our rules, but our antiquated statutes or haven't been updated in a while are preventing us from, hence the need for the technical fix. So it all is kind of, right, but the rules are given to us to be able to do in confines of the statute.
And how do the sponsors alert you when something in their proposal is going to impact
That would
us?
be great.
That would be great. And sometimes that does happen. So sometimes that does happen. We do have legislators that reach out and they say, hey, this may impact you. Would you like to, know about it? That doesn't always happen. And that's part of if you see something, please.
Yeah, I think,
Go with that line.
yeah, I think, the relationships I have, if it's about nursing, someone's
Yes.
reaching out to me, asking, there's really great conversations I'm having right now. I'm representing the board. Laura has joined me on some to really just share information, but we can track it if someone didn't reach out to us. So, but
Yeah.
it's being very proactive because if they pass law, we don't know about it, it's very challenging.
Right.
But given the many, 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 many steps and the many, many different places, we're hopeful. It's just hard to know which ones will be successful, which ones won't. We have to figure out what to prioritize. But please, yeah, I think I'll say it one more time for Kimberly. Let us know if you're hearing of something. Maybe we know about it, but make sure we do.
Do we have a list, and maybe we do, and I just have forgotten, but of some of the statutory cleanup we were looking to introduce?
I think we brought it to the
Well, no, we just got the bill back.
Oh.
We just got it back and you have a certain amount of time to have discussions around what they got right, what we need additions. So the past week has been in those conversations and then we can bring it.
So just one more question, sorry. So somebody could bring a bill and say, and it could pass, that totally like upended some of our rules. So like somebody could say, we think that clinical, like it should be 1 to 20 and it passes, and then we have to change up all our stuff. Okay, just checking.
Yes.
Yeah, and it's why we stay engaged, and we're really lucky in Oregon that I think the legislative branch and the executive branch works well together. In some states, when I'm at the National Council Board of Nursing, I know that not all boards of nursing directors are from the executive branch are respected in that way and are even allowed to testify. Where I get invited to testify and informational only like next Monday, which I'll share out. So we are in a really good place that the legislative branch, as much as possible is working with us upstream. But my goal really is to inform them, educate them, partner with them, collaborate with them, because laws can get passed that don't have all of the information. I'd say one of the biggest examples of that happens across the country and is happening to other regulatory boards is the compact, the conversation, right? Each compact is different. Each compact is run differently, led differently, and so each board in each state has different it has different impacts on them.
Yeah, and I just add that that's the piece about what our role is to provide that very neutral, fact-based information that's just really focused in on the data so that they can be making the best choices or the most informed choices when they're making these decisions. Hopefully. There it is. Full circle. All right. Anyone else? No, it's the end of the day.
Any other questions or comments? All right. Are we too early to end the day? All right. It is 3:20 PM and the Oregon State Board of Nursing meeting is now adjourned.